which is consideration of a proposal to conduct inspections of all pharmacies every 4 years. The board's charge to regulate the pharmacy profession necessitates routine inspections of licensed facilities to confirm adherence to or identify failures in adherence to the requirements of pharmacy law. Failure to perform such inspections makes the board's enforcement program reactive rather than proactive, because the inspections are currently done when the board is investigating potential violations of pharmacy law from a complaint or other information that would trigger an investigation. For a number of years, the board's policy has sought to inspect all facilities every 3 to 4 years. The board has been unable to complete these routine inspections of all facilities with any regularity, and in recent years has had to substantially reduce such inspections because the board's first priority has been investigation of complaints and performance of the new annual mandated sterile compounding inspections. While thousands of inspections are being completed, the inspections occur generally as part of the investigative process prior to issuance or renewal of a sterile compounding license or as part of probation monitoring. There is a chart on page 8 of the packet handout which outlines the number of inspections by fiscal year that the board has conducted. And as you can see, they've been pretty consistent. In fact, probably fiscal year 14-15 is actually a little higher than the previous year. Mandatory inspections on a routine but random basis would enable the board to perform compliance inspections and focus more on education to licensees about pharmacy law, as well as identify early problems that will prevent more serious consumer issues from developing. And these inspections would be unannounced. Compliance inspections also provide an opportunity for the board staff to answer questions about the law and to complete follow-up inspections of all previously issued citations or letters of admonishment to confirm compliance by licensees. Establishing a policy of mandatory inspections of every pharmacy every 4 years would supplement our current practice of conducting inspections principally for investigation or inspect sterile compounders. The board currently has 6,614 community pharmacies licensed in California. Some of these pharmacies have never been inspected by the board. The creation of a policy directing the board to perform inspections of all pharmacies every 4 years would require an approximate 1,650 routine inspections annually. Over the last 2 years, the board completed 1,215 inspections annually, and these are routine plus investigation inspections. At the December 2015 board meeting, or enforcement committee meeting, the committee recommended creating a statutory mandate to complete random unannounced routine inspections. However, at the February 2016 board meeting, the board referred the matter to the enforcement committee for additional discussion about ways to ensure more compliance inspections are performed. So at this meeting, our committee will resume its discussion. And I guess I would argue that right now we are doing annual sterile compounding inspections at all the hospitals. So the hospitals are kind of getting an annual inspection,
They're getting an annual inspection.
while the
Yes.
community pharmacies are not.
No, that is correct.
Okay, so this would kind of allow an opportunity for the community pharmacies to receive the same level, or at least
Not
similar.
annual, but once every 4 years, we would be in to see them, and the focus of the visit would be aimed at compliance and checking those things that we know that are sometimes problematic. Are they doing the self-assessment? Or do they have the notice to consumers, point to your language, posters in place? Are the pharmacies clean? Are everyone there working and in good standing? That kind of thing. And it provides an opportunity, much like with the duty inspector, an opportunity for the inspector to interact with the pharmacist. We actually have some pharmacists that prefer compliance visits than they do actual investigation inspections. So it allows us to educate, and it allows us to see pharmacies in operation. And in honesty, we're going to walk into some pharmacies we haven't been in a while, and we're going to be opening investigations on them because we're going to find things that we didn't expect to see.
So we don't need legislation for this. We can do this as board policy then for the
Yes.
inspections every 4 years.
Yes, and what we're going to do, the one thing that we're attempting to do is to get a staff person to oversee the data management for this, because we can start at the beginning of the year and say we're going to go into these 400 pharmacies that we haven't been in, and during the course, and as soon as we go out and inspect them, 2 months later, we get a complaint on them, which means we have to go right back out and inspect again. But there'll be some of that, but we want to track and make a good faith effort to really identify those pharmacies we haven't been in that are staying below the radar, either because they're not a problem or because they are attempting to stay under the radar.
Have we looked at some of the investigation complaints that we've filed, that we've identified, to see when the last inspection was before
Yeah,
that?
we
And
can-
have we found any trends?
No. What tends to generate is eventually, in part because of the value of cures and how we use cures, we identify a lot of the controlled substances violations. Those of you that are in pharmacies know that in sterile compounders, we started off initially doing corrections, and now we're at the citation and fine because it's our second or sometimes even third inspection, so you're starting to see a higher presence of the board. Our intent is to get you compliant. I think we'll see kind of the same thing. Now, what we have been doing is our 120-day inspections. A pharmacy, after we issue a license, is supposed to operate within 120 days. And if it's longer than that, we are expected to either void the license or do something to remove the license because they possess a license they don't need. That's part of the reason, those of you that want a license months in advance, you don't get it. This is part of this. There's a fraud piece also involved. But one of the things that we have been doing is the 120-day inspections, which sometimes yield results and sometimes don't. Those are at the front end of a career of a pharmacy where we go out and suddenly where we expect to see a pharmacy, instead we see a mailboxes to go location, for example. Well, that allows us to discipline, take action there. But we can identify when we haven't been in a pharmacy. I think I had somebody generate the data for me, but I don't have it in front of me right now. So we kind of have a feel for where we're going. We think that if it stays at the current rate of inspections for the routine and the investigations, we need to add 12 inspections per inspector per year. And if we're really going to focus on those pharmacies that we haven't been in first, then we may have to increase it upwards towards 20 or 40 inspections per inspector first. We will front load them to the inspector, say at the beginning. We did this years before when we used to do inspections, where typically at the beginning of January, I will give you a list of these are the 20 sites you have to inspect before July 1. That allows you to work out how you're going to do it. You can build your itinerary and your work plan around that. We don't have the staff, nor is it beneficial for most people to be hand-fed every other day. Okay, you need to go inspect this place now this one.
So do supervising inspectors then ensure that the inspectors have completed
They will be.
their work, their assignments?
Right.
Okay.
There'll be a monitoring, and that, again, will be part of the staff person's responsibility to monitor that so that the supervisors don't have to do it. They'll get the report, and then they can work directly with the staff on where they're standing with respect to their inspections.
So the motion from the board was to instruct the enforcement committee to discuss the issue further and provide recommendations on how the routine inspections could be completed every 4 years with existing funding and inspector staff. And probably just for what you just summarized, we can go back to the board with.
Right. We should be able to develop a plan that can go to the board in July, and we will have already probably stepped into it because we'll be 1 month into the new fiscal year by then.
Okay. Board members? So saying 12 inspections a year, which is 1 a month essentially, that have to add an addition.
It's going to affect some of them, I think, more than others, but the intent is to find a way to make it a reasonable workload, and it's a different kind of workload. And what we don't want is on the routines where they walk in and they identify problems, we don't want them walking away from the problems. We're going to want them to write the report, investigate, and so they just got some more work. But absent that, and we know from experience, typically that used to be about 15% of the times where we didn't have a preordained reason for walking in, about 15% of the time we'd open an investigation on it. So if it stays at that level, it'll be manageable. If it becomes a problem, we'll have to find another way to work it. Our goal is to monitor this, particularly for the first 2 years, and at that point, we'll know where we stand with respect to whether or not we're going to hit our 4-year target.
When they go out, do they have uniform checklists to go through or something?
We use the
program?
self-assessment generally. Most inspectors have certain things. They go in and we monitor for compliance with consultation, for example. That is a very big deal, and all the inspectors should be, I believe they are, should be monitoring to make sure that consultation is occurring. But we look at their self-assessment. We want to make sure that they've done it, and then we monitor the self-assessment against what we see with our own eyes, and then where we see a departure, then we start putting down the violations.
What determines what goes into the self-assessment, when it's modified?
The self-assessment has to be done once every 2 years or whenever you have a change in PIC.
Oh, no, the different items on the self-assessment?
The self-assessment forms themselves were developed by inspector staff about 5, maybe 6, 8 years, probably 10 years ago now. The board then approved it, and you still approve it every year,
Right.
or every other year.
But, so the items are suggested by the supervisors, the field supervisors, or are they put on there to educate? Or, when I filled out a self-assessment, every year it seems like there's different items as they're updated. What determines what items go on there?
When there's a law that has changed, it gets added to it. It's really an assessment of the things that you have to do, and a pharmacy that does it will be compliant with the law if they follow the requirements in the self-assessment. So it's not a list of policies, it's actually a list of compliance items that state, this is what the law says, are you compliant with it?
Does it also get modified when problems occur that haven't been seen before?
Well, if there's a law that changes, it's not a wish list of things that you should be doing in a pharmacy, it's things the law or board regulation requires you to do. So it's intended to keep, they were really developed because we weren't able to inspect every year. And so instead, as many other state boards did, I think we may have been one of the first that did it, we developed, if we had gone into the pharmacy, this is what we would have looked at. So it allowed the pharmacy to assess their own operations as if they were being inspected, but instead of the board inspector doing it, the PIC does it, which is why it's such an integral part of all of our inspections when we go out. And by the way, starting the next compliance meeting of this committee, we will be bringing the 2017 version of the self-assessment to you. We'll expect you to be fully ready to review it at that point.
Okay, any other board comments? Public comment? Okay, if not, we'll move on to
Janice, I think, had a comment.
Janice.
I just want to clarify, you meant 12 inspections per month per inspector, not 12 per year.
No, I meant 12 per year initially. Based on the numbers that we have in front of us here, it's 12. We ran numbers differently, and it came up to 40 a year, which would be 20 every 6 months. But we're not, it depends on how the data is arrayed. So we're just going to step into it, which is why it's going to take us a year or two to really figure out how we're going to hit it, and are we going to hit it.
And that's with all inspectors or the inspectors on the compliance
It's all
team?
inspectors
Yeah.
right now, because I don't think we can hit it any other way.
Except for you, you have to do 100 a year.
All right, moving on to compounding matters. A, update on the status of the board's sterile compounding regulations. This is Title 16 California Code of Regulations, Section 1735 and 1751. On May 8th, the board initiated formal rulemaking to update California's compounding regs. A chronological timeline is included in your packet with the file submitted. The board approved the final text on January 19th, 2016. File submitted to DCA for review March 10th, 2016. The board set the effective date of the regulation as January 1st, 2017. The file is currently reviewing by DCA. So DCA has had it since March 10th. So where are we with this regulation?
We've gotten a 90-day extension so that the director has time to review it and the administration can review it. Laura, is there anything more you want to add?
Have you finished your review yet, Laura?
So there's been some, yes, preliminarily. So been some back and forth that have gone on, and we're still working on it, but we're hoping that it should be done, well, There have been some modifications that have been made by staff, so even though it first came to the director's office in March, there's been revisions that we received since then, and so we're working on those, through those.
Revisions after the board review?
Not to the language itself, to the package, because what we're looking at is not just the actual language of the thing, but everything that you need to submit to the Office of Administrative Law.
The intent is to keep it from going to the OAL and then being sent back for corrections back and forth. But at this stage, do you see any reason we would have to do a 15-day comment period to add things to the rulemaking?
Not at this point.
Okay, the concern is we've basically, the board has set the effective date as January 1st. However, if this is going to take longer, because we need to give the pharmacies the opportunity to review the regs, and we're going to have a waiver discussion coming up, but we need to have these finalized before we can do that. Because otherwise we have to reconsider that January 1st deadline.
Yes, but they're not going to be finalized until OAL actually approves them.
Right, but we have to get them out of the department first.
Right,
Right.
right.
Before they go
And then
there.
it still goes through agency, and then it goes to OAL, and we've got
Right.
the Department of Finance that's going to have to do the fiscal review.
So what's our best estimate right now on even if things go well from this point on?
We probably have, it was a 90-day extension, and you got that when, Laura?
I
figured-
believe our final date for the director's review is I asked just last week, it was the end of August, toward the end of August, like August 20th.
And that would be the 90-day.
Right.
So then it still needs to go to OAL.
Right, and OAL has
How long do they take?
days, 30 days.
So we couldn't have, this may not be ready till October, November?
Yeah, that's
So
possible.
we may want to go back and look at at a
Expert.
future implementation date that's further after January.
Well, we can go ahead and we can add that for the July board meeting. At that point, we'll have a better feel for where we are with respect to the rulemaking file. Because if it can get through the department in June and go to agency, then we're better positioned. We may not have to move it back.
So can we get a motion to just update the board at the July board meeting with the potential of extending the implementation date based upon the status of the regulation?
So moved.
Second? Any public comment? All in favor? All right, moving on to B, presentation by the Office of Statewide Health Planning and Development regarding its process for reviewing structural modifications needed in healthcare facilities. At this meeting, Glenn Gall, supervisor in the Facilities Development Division of the Office of Statewide Health Planning and Development, will provide a presentation on the process for reviewing structural modifications in healthcare facilities. A copy of the presentation will be provided. And part of the reason that and Mr. Gall, thank you for coming. Appreciate your attending today. We, as part of the sterile compounding regulations that we were just discussing, there are going to be some requirements in terms of structural modifications that will be required to pharmacies that compound hazardous materials specifically. And before we start talking about waiver requirements and when these will be officially implemented by the facilities, we wanted to get an idea from OSHPD as far as what you believe the timelines will be, and so we can consider that when we talk about timing. So thank you for coming.
I guess. Thanks for having me this morning. It was a bit of a surprise that you'd ask me to come here to tell you about our building project review process. But then again, I have looked at your regulations. Most facilities in needing to comply with these regulations going forward will have to do physical alteration to their existing facilities. And frankly, after listening to some of the discussion previously about consolidated license, campuses, buildings, and all that, I sort of wish you'd asked me about that, because it's a lot more interesting and near and dear to my heart with outpatient clinic buildings.
We
But-
could invite you to a future meeting if you really want to go. In all
I'm here.
seriousness, we will be happy to do that.
Not a
Always
problem.
welcome.
Okay, this is really a high-level flyover boy, this color is extreme, isn't it? Do you guys see all that yellow that I do? Yes. Okay, I'm not losing my eyesight then. All right, really this is really a simple process. Believe it or not, OSHPD is a state-level building department responsible for checking plans and providing inspection oversight for hospitals, licensed skilled nursing facilities, and we also end up writing regulations for freestanding outpatient clinics and freestanding outpatient clinical services of hospitals, as well as writing regulations that apply to health facilities licensed by the Department of Corrections. They're fondly known as multiple groups of regs. OSHPD 1 applies to hospital buildings where inpatient hospital services take place. OSHPD 2 applies to skilled nursing facilities that are single-story wood frame or light metal frame. The clinics are fondly known as OSHPD 3 facilities, and those are under the local jurisdiction, but our regulations apply to those licensed entities. So we have architectural, mechanical, plumbing, electrical, and with the facilities that we review directly, also structural requirements. Design process. And this is high level because we're not sure what the facilities will need to do to respond to your regulations. Some of the facilities will be in a lot better place in terms of complying with your regulations initially, based on how they do what they do currently, and also whether or not they've upgraded their facilities lately. Because I have seen projects that have gone through our office with clean rooms installed, whether or not our requirements required them to put those particular facilities into their pharmacy facilities. That said, design process, same as any project that would be coming to OSHPD. If you're adding a new bed unit or doing alterations to your pharmacy, it's a standard submittal process. We look at schematic designs when asked. I'd actually assume that some of these projects would come in for preliminaries because looking at your requirements, the code doesn't really, and when I say the code, the mechanical code, the building code, really don't address these facilities very well. The requirements that you're coming in with for pharmacies, Chapter 1250 of the building code or Section 1250, is not to the same detail as your requirements are putting the requirements on the facilities. Thereby, they'd probably try to rely on some of our expertise relative to having seen these facilities and being somewhat familiar with the requirements in terms of ISO level and also the physical configuration of the environment. Construction documents, they're required to be prepared by architects and engineers licensed and submitted under their purview to our office for review and approval. Once we have looked at the plans and approved them, the process takes place, and you'll have to forgive me with these 10 slides. I had a staff member prepare them for me, and they stuck in all kinds of stuff that I wouldn't have normally addressed, but they were thorough, so I'm happy. I was getting ahead of myself on the presentation, on the slides at least, but that's a typical OSHPD team that is looking at the design of the project. OSHPD has a similar team that conducts the review of the project. We have architects, mechanical engineers, electrical engineers, structural engineers, fire and life safety officers that do these project reviews. Again, these are just the basic phases of design. Along with the submittal process to OSHPD, we would see construction documents final construction documents submitted to OSHPD for review. That's what we'd review and ultimately approve. And then once it was approved, it would go into the construction phase and we'd oversee that construction. Now, this is the OSHPD plan review side of the table. Again, an architect, structural engineer, mechanical, electrical, and fire and life safety officer. Project types, the H and the S, and there's a little bit of a misnomer in the presentation here as I'm listed on the agenda. We consider structural alterations to be addressing primary structure of the facility. So if you're talking about a lateral support system, something that's responding to physical loads on the building, an earthquake, that's a structural alteration. My sense is that the majority of these projects would not be structural alterations. They'd be interior remodels, and they'd be S-type projects. And there's our review timeline for a normal project. We try to focus on 1 initial review and 2 subsequent back checks as a maximum. The one thing is, too, that's a 60, 30, 30 time turnaround. The better the design team is, the better those numbers get, because you may not get to the subsequent back checks. Then again, it says 60, 30, 30, and we try to dispense with those as quickly as possible. Depending on who the facility hires, we could go 60, 30, 30, 30, 30, 30, 30, nearly ad infinitum.
So are you involved with earthquake retrofit? or not?
Absolutely,
Okay.
yes. That's our office that does that. We preempt local building jurisdictions to do it.
Thanks.
So again, most of our projects would not involve primary structure, is my guess, on these types of alterations. These are the codes that we enforce. We actually amend them and enforce them. And it's interesting because while the building code, Part 2, Title 24, Section 1250 applies to licensed pharmacies, we reference it, but we do not do the enforcement. Okay, OSHPD actually has requirements in licensed hospitals of 100 beds or more that they have a licensed pharmacy in the hospital building that's under our purview. And then they'll go and follow those 1250 requirements, along with some additional requirements that we list, one being USP 797. We talk about where you can locate hand washing fixtures and drains, in essence, in that compounding area or in the pharmacy area. It's fairly standard stuff. Our requirements are put forward very, very minimally, not very prescriptively, because frankly, the folks doing the design relative to pharmacy design typically have the expertise at hand to know what they need to do. They're not really needing low-level instruction on what they're needing to do, and we're just verifying that they've done it correctly per the codes, including the mechanical code, Part 4. Oh boy, they even put our pharmacy requirements on the slide, so if you can read the fine print, that section 1250 over there is actually your section in the building code. The section 1224.19.1 is the OSHPD section that we do enforcement of for hospital facilities. We can go back there.
Can you just tell us what section it says? I think everybody's
It's just
having a
really
hard
hard to
time
read
seeing
the
it.
slide.
It's California Building Code, section 1224.19. And it's a required basic service of a hospital, pharmaceutical service space. And licensed pharmacies have to be provided for hospitals of 100 beds or more.
So 1224.19?
Yes.
Or
And if you notice, we have some language in there that references Class 7 or Class 8 ISO classifications. as well as USP 797, but those are very general references to needs to comply. We pull them from national standards referred to as the Facilities Guidelines Institute requirements for design and construction of health facilities.
Can I ask, is that only for hospitals then?
Correct.
So if it's a clinic,
Now, let me balance that. These OSHPD 3 facilities are facilities that are freestanding and separate from inpatient hospital buildings. Okay, so they may be another building on the campus, they may be a building across town, but they're under the hospital license, licensed as an outpatient clinical service of the hospital.
so it's the state's consolidated hospital license?
Yeah, technically speaking, it doesn't have to be a consolidated license. They can license outpatient clinical services on their license, and it's not a consolidated license, it's just their standard license with an outpatient designation in a freestanding building. And yes, that would apply to those facilities under a hospital license in a freestanding building that might be across town. And they're referred to as OSHPD 3 facilities, as I said. We list that when outpatient clinical services of a hospital are provided, they're not covered by the OSHPD 3 requirements, which pharmacies are not. You're to refer back to the applicable section of 1224, which for a freestanding outpatient pharmacy building or pharmacy building that was under the hospital license, these would be the applicable requirements. And they'd be enforced by the local jurisdiction unless the local jurisdiction didn't feel comfortable or capable. Then OSHPD would do the overview for the OSHPD requirements on that locally permitted building. And all of these listed on a hospital license as an outpatient clinical service would have to show written evidence of OSHPD 3 compliance, whether it came from the local building department or whether it came from OSHPD. But that's what licensing will ask for when they have to license these facilities.
So I just looked up the fine print on 1224.19, and it basically just says that you need to have a hand washing fixture and you need to have accessible to a restroom.
It actually goes beyond that as well. This section is a little bit longer. This is sort of an edit. It's a snippet. One of the things is we talk about multiple rooms as well. And I guess I didn't want to get into the detail because one of the things is when you've got a higher class room, we have actually additional requirements that occur over in the mechanical code due to the ventilation standards. So all of a sudden you have to have separate rooms. You'll have an anteroom, as an example, and the ventilation requirements of that given room are different than the room where the drugs are either compounded or otherwise, broken down, I guess. You'll typically have 3 spaces, 3 physically separate spaces.
So is that under 1250, which is the right side?
Yeah, 1250 is the right side, and there's more to that section as well. They're both within Title 24, Part 2.
I found 1250, so that actually has the details for compounding.
Uh-huh. There's also Title 24, Part 4, which is the mechanical code. And that gets a lot more into the ventilation standard. Part 4. The OSHPD process. Required written approval?
No, I'm just curious.
Oshbod, we require drawings and specs to be approved. A building permit is issued after the plans are approved, and there's a requirement for a testing, inspection, and observations plan, which lists required tests relative to the given construction project. There's always an inspector of record involved on a hospital project. That inspector of record is hired by the health facility as required by law, and we provide oversight and quality assurance of that inspection program that the facility puts on their projects. These are all the folks that may in fact be overseeing the project in construction. There'll be the inspector of record as a given. He's the eyes-on person during the entire duration of the project. There's an Oshbod compliance officer which oversees their activities. A district structural engineer only if there's structural alteration of the facility. There's a field fire and life safety officer. There's the architect of record. That would be the design architect responsible for the project. They're required to make site visits. Along with mechanical engineer, electrical engineer responsible for preparation of any of the documentation. They're required to do on-site inspections. Amended construction documents are when there's changes in the field from the approved documents. They're actually taken in and reviewed by the office to make sure that the project hasn't gone out of compliance. And as you note here, they can be done under field review, which is done on site, under rapid review, which is a 21-day turnaround, or an office review, which may be extended. Depends on the depth and breadth of the change. Oshbod project closeout, this is when the project is in fact completed as it was approved on the documentation. There'll be verified compliance reports where everyone submits final reports based on their physical, visual assessment of the facility construction. So they're verifying that in fact it was completed per the approved documents. The office will issue a certificate of occupancy, letting licensing know that the compliance with Title 24 has in fact been achieved. Then we kick over a letter to licensing. Licensing will typically go out, allow for staff and stock of the facility, and do whatever they have to do on the licensing end of it. And then commissioning of new space, real basic. I assume this is where you guys come in and say, okay, you're good to go. You're licensed to do these services and the like, along with all of your basic, okay, we're going to inhabit this new shiny space that we built. Real high level, folks. And I know you're wanting to know what codes are in the book, aren't you?
Well, I'm just wondering how, I guess the reason I was looking at it is as we update the codes, and this is actually in response to federal standards, so USP 800, and what is the process to update these equipment codes that you have so that they're up to date and we're consistent?
One of the things is we have quarterly meetings anymore with CHA. They used to be every other month, I think. They've got some folks that deal with pharmacies for their members. Kaiser was up here earlier. Sutter's always at the table. Mercy's at the table. So we interface with them relative to the requirements that you regulate facilities with vis-a-vis the way we regulate facilities, along with licensing and certification, or CDPH. We participate in writing of national construction standards for health facilities. That said, that's where our codes tend to go, our building codes. I go to places, exciting places like St. Louis, sit there for a week at a time, talking with other architects, engineers, clinicians, providers, in terms of what that guidance for construction of the facility should say and how it should say it. That said, we also have federal involvement at those meetings. So when they're coming down the pipe with additional requirements, typically, the national standard will respond to those. The building code process takes about 18 months. But then again, to put those national standards into the California book and make them enforceable, we usually see them well after they've been, released nationally. And I'd say for us to get to the most current standards, we're looking at 2 to 3 years. Now, I don't know how you folks do building code changes. So I've never seen anyone from Consumer Affairs Pharmacy at any of the Building Standards Commission meetings, or it's been a while since I have. I mean, it has been a long time. And it's much different than the OAL process. It tends to be a lot simpler, as I understand it. I'm really glad I don't have to go to OAL. But in terms of syncing up our stuff, we try not to tread on anything that you say, which is why our requirements are very basic. They're very minimal. Details of a licensed pharmacy are in 1250. They're your requirements. Should you want us to make adjustments to our codes, I'm the guy you'd talk to, so just let me know. And we'd put in a code change proposal, which again takes about 18 months. We go through a public vetting, public meetings, commission meetings, code advisory committees, some of which happen in this room with the building standards up here, and they're really sort of punched out relative to the implications in terms of adoption of a standard.
If we have in our pending regs certain air exchanges per hour, or in certain
Like 30?
requirements, yeah.
Yeah, I saw those in here.
So how does that work, given that your requirements don't have that?
Well, see, the thing is, they have to comply with your requirements, which is why we don't prescribe the requirements. Because we're either not keeping up with you, or we're not looking at it to that degree. Some of the requirements I saw, I had all the folded pages from Article 8, or I guess, Attachment 8. Some of those things I'd see as their appropriate location might be better in the mechanical code. And that's really so the designers out there, the mechanicals, the architects and the like, would actually know what they have to do. Because, I mean, they have a hard enough time with these books.
Yeah.
Never mind, we're looking at what, this is Title 16? It's a mismatch for engineers and architects, I think.
But how can we manage that if it takes you 2 to 3 years to get the, 2 to 3 years, we're going to have more changes.
Well, no, it's an 18-month cycle normally. They have a triennial cycle, so these things are updated every 3 years based on the International Building Code for the building code. And we're mandated to adopt the new triennial edition every 3 years in the state. There's also a supplement cycle, which is a year and a half, so that's the 18 months. So every 18 months, we're doing new code proposals.
Are there any
these
plans
codes.
to try to streamline this to shorter than 18 months?
Oh,
You're asking for a lot.
I'm already planning on retiring. Don't drive me there quicker.
Where are
No,
we?
Really, in terms of the 18 months, the way the building codes process works, the things have to be adopted and available from the publication date for 180 days before they go in force. So even that said, you're adding time to that 18-month process. But with all of the public meetings that go on, with the code advisory committees and the agency due diligence in terms of beating the bushes for interest in terms of affected parties, the 18 months is really pushing it. Sometimes it's, I wish we had more time, because we also have to go through Department of Finance. You were mentioning putting your reg through agency. It hasn't gotten any easier putting it down to 18 months.
Do you typically find any, a lot of significant changes that get made throughout the process?
From triennial to triennial, yes.
You do? Okay.
There's also emergency authorization. Let's say that you folks came out with a standard that met the standard of emergency relative to public safety. Then you propose the code changes written to the Building Standards Commission. They make the determination that it meets the measure of an emergency, and they will approve it there on the spot, and it's immediately enforceable. Then you have 180 days to make it permanent.
Got it.
And that's when you go through the public process and solicit comments, respond to any comments. If at the end of that 180 days, you've dispensed with all the comments, adequately responded to them, or justified the regulation, or possibly even changed that regulation based on comments received, you can make it permanent in a much shorter period of time, but in the meantime, you've had it applied the whole time.
Thank you.
So where are we in the 18 months right now in
Right
terms
at
of
the
the timing?
beginning.
At the beginning?
Yeah, it's, like you were mentioning, a January date for these new requirements. The 2016 codes, this is the 2013 pictured up here, is applicable and enforceable on January 1st, 2017. Right, it's out there, it's penned, it's done. The publication date for the code is actually designated as July 1st, which gives the 6 months of public availability. We're going through proofing of the document right now with Building Standards Commission. So the publisher's printing, and we're looking and say, that's not what we said, and getting that all right.
I think that the question that we wanted to actually also get your response on is we are issuing new regulations that are going to require some building changes, and as you stated, that's in our purview, given our public protection role to do that. So let's talk about the 30-acre exchanges per hour. We're saying that needs to be required. And we're developing a waiver process because we understand that there are going to be hospitals that are not going to be ready to go on day one because of the natural cycle in budgeting and construction that's going to be required. One of the things that we keep hearing back is that OSHPD has so many delays in the review process that's going to add additional time.
It's all your fault.
So we wanted to hear directly from the expert, what kind of timeline should we build in our waiver requirement for OSHPD review and approval?
Friendly suggestion, I wouldn't call it a waiver process. As I read
Delay.
it, you're still required to comply. It's a
Yes.
delay in compliance, and it has to be justified.
Correct. What do you recommend we include in the justification? Or do you have
Well-
a process for that already that exists?
See, here's part of the issue. We can't review plans if they're not sitting in our office having been submitted.
Okay, so I submit plans to you on June 1st.
On June 1st, we pick them up and the clock starts ticking. 60 days from now, we have to have that first review out.
First review means that response back to the hospital will tell you this is
Runs
what
back to the designers,
the
really.
designer, okay.
Yes.
And then they would then modify that design.
Correct.
So
They'd modify the design, resubmit.
September 1.
Once we get those drawings back, 30 days we have to get it back to them with additional comments, if any.
Okay, and how many times does that cycle typically take in a hospital design such as a
Literally,
clean
we
room?
target 1 first check and 2 back checks. When we get beyond a second back check, we'll call in the facility owner and the design team, because we don't like to keep these things going either. I mean, it's really in our way at that point. Frankly, we've done as much review as we can, and if we've got a non-responsive design team, the only one that can correct that is the provider, the facility itself, because they hold the checkbook.
Right.
And like I said, it could be 60, 30, 30, 30, 30, 30, 30. And sometimes we get submitters like that. There's nothing we can do to compel them to do what they need to do.
So we have 60 days, you get a response back to them, then they're going to take a little bit of time to make the changes they need to do in their design before resubmitting it. How long does that time typically take before you get the second response back?
Depends on how good the design team is, one. Also, how hard the client is pressing. So
Really?
I'd suggest that
Squeaky wheel.
Well, I'd suggest if you had good definitive dates in your requirements, those particular clients will press a lot harder on the design team to get it in and out of our office quicker.
So there are design teams that are probably very experienced with this and therefore can shorten the time.
Let's say I'm an architect.
Mhm.
I am
But
an
you are.
architect.
Yeah, let's say you are. yeah.
At times, certain things don't rise to the level of importance on your table as your clients'
Got
table.
it, got it.
And that's part of the difficulty that we find. We actually were requested by hospital facilities to put into our regulations suspense dates for resubmitting back checks. And that was to compel the design professional to keep this on the front burner. Because we were having difficulty with them resubmitting.
Sure.
And we didn't have a time that they had to resubmit in, and right now I think it's at 90 days.
But there are
So they have
probably
90
some
days to
design
resubmit.
teams that are so familiar with it that they're not going to get many changes that.
Right. There'll be minor corrections, minor pickup.
So if we allotted 6 months, is that realistic?
I think it is. Here's the other piece, though, construction. Okay? I was talking now about the review and approval side. Construction in a live facility is a lot more difficult. Depending on what their physical environment is, whether they have other pharmacy facilities to rely on while they do the alterations to the one that they're going to peg for their compounding pharmacy. Even 6 months might be a push. Because it's not as though you can just barge in and start tearing stuff apart. Plus, you're looking at fairly high-level mechanical systems in this instance.
There could be also some venting changes that are going to
Absolutely.
be required as well.
I
Hey,
mean,
Christine?
where you actually go out of the roof and relative to its proximity to other things that are like fresh air intakes on the roof, that might take some work.
Christine, did you have a question?
Hi,
Hi.
Supervising Inspector for the Board. Part of your approval process before they start the construction, is there a timeline in that approval, the estimate for the construction start completion dates? So we would have an idea?
No, you actually have to pull your permit after an approved set of documents within a year. That said, they could either take their sweet time or get on it.
Okay.
Yeah, at times we'll get, there was talk about accreditation surveys with Joint Commission or whoever is doing the accreditation survey. Licensing at times will do life safety surveys of facilities, and they'll give them a citation. They'll give them a tag. They put really short suspense dates on some of those tags. When they do that, it really gets some attention from the facility side of it, because at times they have to do physical alteration of the facility. Fire sprinklering is a big one. If they're under sprinklered in the facility and they get a K tag, they need to get that fixed nearly immediately, sometimes 90 days. When it's a project of that sort of size and scope, you can do it in 90 days, but sometimes they still have problems getting it done within 90 days, because you've got to go out and get a contractor on board. That contractor has to get approved documents into OSHPD. OSHPD has to review and approve it. So there's a lot of things that can get in the way. And then you physically have to make time to get into the facility and do the work when you've got patients all around. That said, I couldn't give you a great ballpark, because I'm expecting that the scope of the projects in different facilities is going to really be varied, depending on their current physical environment. You know, where they're located, whether or not they've done upgrading to their pharmacy prior, relative to its closeness in the new requirements. Because frankly, some of them haven't done a heck of a lot. We have some old facilities out there that don't do ongoing alterations to stay current.
If we do start receiving these waivers, would you or someone in your office be willing to help us review these to see whether the waivers are timely, whether they're appropriate, given the requirements that are in place in the plans that are submitted?
Well, here's the thing, I'd say we could do that, but we don't really have any teeth to.
No, I'm not asking, we understand that. No, we're just the technical expertise from from you or your staff, so that you could advise us and say, this looks realistic, or, because there is a public protection mandate that we need to adhere to. And we need to make sure that we are receiving information, that these are legitimate waiver requests, and this does, but we need some technical expertise from the building side to do that.
I think we could provide that for you folks.
Right?
Perfect, thank you.
Now, to what degree, I don't know if we start getting thousands of these things. But really, I think it's also in penning your regs. There's certain incentive that you can put in there that gets it to go a little bit quicker.
And we've even thought it may be, I mean, we haven't really discussed it with the full board, but just to let the public know that these sites are pending waiver. They've requested waivers, so they're not fully compliant yet, and have that as a public information topic as well, so that those that do adhere will remove that waiver requirement from their license.
Well, and
Like, we get calls all the time right now about how long our process takes. And I always candidly say, the better you are, the better we are.
They always blame Oshpot all the
Well, no,
time.
it's
7 years. I heard 7 years for years.
No,
that
it's real easy. We're a paper tiger. You know, it's like, oh, Oshpod. But nobody knows that we're just the building department. We don't really carry that big a stick. We do our job, and our job happens to be public safety, seismic safety, and it's an involved process. You know, the difference that I see with Oshpot as a building department versus having dealt with building departments and also having worked for the feds, Oshpod's documentation process is a lot more detailed because of the criticality of the outcome. And you're doing a commercial office building like this place, if an earthquake happens now, most of us can get up and run out. You're not living that way in a hospital, and oh, by the way, you'd also be expected to receive patients after the event.
Right.
It's important stuff, so it's given that level of scrutiny. And we do have a lot of processes that people can fast track what they're doing. This said, we've got that rapid review, I think, was up there relative to amended construction documents. Depending on the scope of the work and just what's involved in the work that's presented, there's a possibility that one of these projects could be submitted and reviewed under a rapid review, which would be a 21-day turnaround. It really depends on the current physical environment that they have and what it's taking them to get from their current situation to the new requirements. Because some facilities will be ready and easy to do these projects. Other ones, it'll be a lot more difficult.
Now, this wouldn't apply, though, to any pharmacy that is not in a licensed healthcare facility. So, because our standards are applying to everybody, every pharmacy that does compounding.
Okay, we wouldn't be involved if it wasn't in a licensed health facility of the types that I mentioned.
Okay.
Okay, so hospital, skilled nursing facility, we'd be involved with those very directly. There is a possibility that we'd get involved with a freestanding licensed hospital pharmacy, remote from a hospital building where inpatient services are given. But even those, typically, they're done at the local jurisdiction. We provide training to the locals to try to get them to pick up their responsibility, because frankly, their processes, a lot of times are a lot more ready than ours. You know, I mean, we deal with ongoing hospitals. We've got the retrofit program right now. We don't need extra work. And with those freestanding buildings, we try as hard as we can to prepare the locals to be able to do that responsibility. But there are times where they just don't feel comfortable or capable. They've been cut with local cutbacks, and frankly, they don't have the staff on board to be able to look at it adequately.
Laura, did you have something you wanted to say?
It's kind of gotten lost, but any waivers that the board would grant would definitely be a public record. I mean, so anything any formal action of the board is generally a public record. Now, whether or not the details of the plan would be public is a different issue that we'd have to look at.
Well, I was
once
talking
that's
more
looked,
about when
but-
you did a search for the hospital pharmacy, it would show up that a waiver has been pending due to the fact that it's not yet complying, so that it would be publicly available on a search.
Yeah, that,
On the license
right.
that's
You're
attached to
talking
the
about
license.
the availability of
Yeah,
the information.
The information,
right.
rather than having to dig through minutes or such to find that.
We may have to create special place on our website, because in order to append the licensing record may be a problem. So we could do it another way, maybe. Because we want it expedient, we don't want to have to wait 3 years to do, we don't want to wait 7 years.
No, I've got you. I do have well, 7 years. Did you just pick that? out?
Seriously, no, I kept hearing 7 years.
Guess what? If you do a new billion-dollar health facility, it'll take you 7 years. Not 7 years in Oshkosh.
Well,
7 years to construct it?
Yeah, absolutely.
you're getting full credit for the delay, or for the period.
What can I say?
So if you were in our shoes and we are going to allow hospitals that aren't ready today, and the waiver is going to, in terms of applying for a waiver, what are the components that you would believe would be important to obtain if you're part of our review process to be able to ascertain whether that waiver should be granted?
Definitive dates as to when it would be submitted. An initial assessment of what the project would involve, whether it be, one of these S projects without primary structural alteration, or an H project with structural alteration. In general, the scope of the project. Because we'd require something that we call a functional program for this type of a project. This is not maintenance. You're actually doing the project for a purpose. We ask you, what is the purpose of your project? That's a separate document called a functional program. It looks at the project, what you're planning on doing, how it affects other ongoing operations of the facility, but it requires the facility to actually go through a planning process of how they're going to go through their project. That helps us because we also at that point know the scope of the work and physical alterations that might be required. Thereby, you could put it in a better box relative to timing. A scope, fiscal scope. So how much they're thinking this thing is going to cost them. And I guess whether or not they actually have design professionals on board yet.
Identify maybe the design professionals are using?
Identify the design professionals of record. And a lot of the folks that do OSHPD work do a lot of OSHPD work, but then too there are some facilities that are in farther parts of the state that don't have access to those firms that do a lot of OSHPD work. They sometimes have a little bit more difficulty in getting the stuff in and out of OSHPD.
Anything else you'd, and then we could review all those elements and then look at their dates and see whether it's realistic, but when the board reviews it.
And I've got another question for you, because I heard the date of the 1st of January to have the regs on the books, right? What was your timeline in terms of compliance?
Well, there are certain parts of the regs that do not have anything to do with construction. So that's why we're talking about all the regs. So there's additional portions that involve policies and processes. I don't think we haven't really discussed the timing because we kept hearing from all the hospitals that they would require time to do this. How much time, we don't know yet, because we haven't seen these waivers and we hadn't talked to you. We kept hearing this 7-year OSHPD review.
I can't buy that. I wish I could take that more seriously, but I've heard it so long, and it's such an old excuse, and it's an excuse for my peers.
Well, here's an excuse to show them wrong. What we were looking at, I think, though, was to do this maybe starting in the fall so that we could have those people that were looking at waivers in place. But it kind of begs the requirement that we have to have the regulations in place first, or else what are we waiving from? Although, once we know that OAL has approved the regs, even if it occurs before the implementation date, which would right now be January 1, during the fall, that would give us time to sit down, work out a process, work with the hospitals that are out there on the front end, and we could actually work a process in place. And we would be positioned better to be able to do this so that we don't wait until January 1 and suddenly we have 400 sets of plans coming in.
Is it possible also that by
one of 7
submitting
years.
and filling out the waiver paperwork, they would prep themselves, be a better position for OSHPD review? Because
I'd
we're following the
suggest
same process.
Because some of the stuff that I said they should be listing are the initial steps in getting your project together. At least it would engage them.
Right.
And like I said, we can't make them submit. But at least we can put them on the path of, this is what you need to do to submit.
That's-
And I don't know if there's a drop dead date, that's out there in the future for when you'd like to see this done. A lot of people, though, schedule from that date, okay, with a construction project. They don't go into it saying, oh, it's going to take 6 months, 8 months, 12 months. They say, we need this by, and then they start counting backwards. If you had a more definitive date as to you need to have this done by then, it might be beneficial to the facilities.
What do you typically recommend with projects like this, or regulatory changes that have this level of change? What are and have a public protection component? What is you place in your requirements?
Depends on where it's coming from. We got a lot of the seismic retrofit requirements from the legislature. Then they were massaged along the way, but there was a lot of input, a lot of discussion. And those are much longer term dates, obviously, because it's a much bigger undertaking. For these sorts of projects, I can't imagine that it's more than a year and a half, 2 years out. They're just not. I'm even imagining older facilities that might have some difficulty getting this done. These are not over-the-top projects.
So the waivers we should receive should be under 2 years.
I'd say so. I couldn't imagine they'd be much more than that, unless they were really dragging their feet on it. But that, too, it's the importance of it. Do you need it quicker? And asking you, is it rising to that level that this is an immediate?
It should be immediate, or else we shouldn't be doing the regulation in the first place. I mean, either it's required or it isn't, and if it isn't required, it's superfluous and we shouldn't be doing it.
And see, one of the things that we do, if we got just swamped with these projects, we'd probably set up a project review team that dealt with these projects specifically. And we've done that in the past. There was a mandate to go to dual wall underground fuel containers for diesel. And there was a drop dead date that was prescribed in the law. We put together a project team that just looked at these projects. So it was just second nature to look at these things, make the comments, turn them around. redirected some of our resources for that effort. We did a similar thing with, there was a CMS requirement for sprinklering of skilled nursing facilities. They had a suspense date, they had to comply. We refocused some resources and put people on those projects because they're all, frankly, very similar. So that's also a possibility, depending on how this thing comes about.
Alan? Greg, any questions?
Your comments are insightful, and the definitive dates that we should set, I think that's going to be important, and so thanks for your comments. Very, very good.
I think this was very insightful, very informative, and I appreciate your willingness to help us and decipher some of the waivers that we'll receive and be part of our process. I appreciate that.
Yeah, and honestly, not a problem, because it's complicated on our side of the table, and we even have trouble getting that word out. And you folks are talking about it with some of the other players in the room, and there's so many moving parts, we only have a little bit of it, but we can shine some light on a little bit of it.
And I think our working together, too, will help the hospitals
what I was gonna
in
say.
terms of getting their ducks in a row for the OSHPD approval process as well.
I guess I can ask, do you deal with CHA somewhat directly in their membership at all?
They're frequently here. I mean, CHA, they have a medication safety committee, so
Right.
they come here to our board meetings. Jenny and I are both on a CHA Med Safety Committee as well as members.
We often do task groups with them. It might not hurt to do, to ask them to do a task group on this issue, since it involves you, it involves us.
Good idea.
And maybe solicit their input on how we're all going to accomplish this together. And frankly, they have a lot of members, and their members they're not quiet. So,
A good idea.
It might not hurt to take the pulse.
Very good idea. Any public comment? Any questions? Oh, wait, we have one.
Lori Hensick from Kaiser Permanente. I just wanted to kind of clarify, because I know that there was a time frame that was mentioned by the presenter suggesting that he would be surprised if it was anything that was going to take longer than 2 years. I just want to clarify, in my mind, that he's talking about purely the construction. So perhaps he might be able to answer, because my concerns are there's other steps in addition to construction.
Couldn't get away that fast.
Yeah. So I'm trying to think, I have concerns because from our experience at Kaiser, it's been longer than that, but that's because it also involves identification of capital, also identification of the space. So 1 to 2 years might seem reasonable for construction, but I want to make sure that the board is aware that if a waiver is being requested for longer than 2 years, that may not necessarily raise eyebrows, because it also involves time spent with obtaining approval for a significant amount of funds.
Okay, I'll preface this response by saying I have a Kaiser card in my pocket.
Well, there went your help.
And honestly, this is not a joke. Kaiser's bureaucracy is bigger than ours. And I understand
plead
what
the
you-
fifth. I
No,
plead the fifth.
I understand what she's saying about getting the capital together, finding the space, and really going forward, because there's a lot of front-ending that the facility does that we don't see, we're not involved with. I really can't answer to that, because it's not we
So
don't
let-
see that.
Let me rephrase the question. So the 1 to 2 years that you mentioned, that was purely construction that you're talking about?
That would be review, approval, and construction.
Got it. So I just wanted to make sure that it was noted that there are other steps that are going to be involved in the process other than that construction.
Yeah, like, for them, who signs the check? That was a big one.
Thank you. Any other public comment?
Hold on, Christine's going to say
Christine.
something. Either that or I'm going to, one of the two of us.
So I'm wondering things. Is there any way that during our waiver process that we could ask or require OSHPD approval prior to or as part of our waiver approval? Then we take you out of the loop because once you've already looked at the construction, we don't have to look at the construction plan because we can put that expertise on your plate because I'm not structurally savvy like that. If your turnaround is realistic like that, could we rely on you for that type of review without you stepping into our realm? And then the next question on that is, then can we have the name of the inspector of record for each and every approval in case we have questions? Instead of trying to play the bureaucracy game for you guys, we can find that person and get it over with in one phone call versus a week of emailing back and forth.
The IOR is not OSHPD's. They belong to the facility. And I wasn't quite clear on your question, because when we do a review and approve the plans go bad. They don't sit there idly forever. Part of the reason being the codes change. The other part of the reason is we have regulations that say that your approval is good for this long if you don't start construction.
Okay. So I guess my question is, being that you have this whole list of people with skills that we do not have, people with those skills, if we have you do the initial approval and give the go-ahead to start the project, that could eliminate our need to look at those plans and look at that, and we can rely on you for the scope of the building codes, the electrical codes, the mechanical codes, which I really don't want to delve into. And then once they have your approval, then we can say, well, you have OSHPD approval, that's fine. I still want one key person that I reach out to, and it's not normally the best idea to reach out to a pharmacist in charge because they're a pharmacist, and sometimes the things we'll have will be more technical, and that's why I like that IRO. I don't care if it's there or at the facility.
What do you mean by the approval? I'm
So
not
if
sure
you
I'm-
tell them, you give them the go-ahead to start construction.
Okay, so we permit the project.
That's what I'm looking for then, after
Right.
you gave the go-ahead for the project. If we could rely on that as part of our waiver approval process, it eliminates a lot of, should I say, heartache on our side, because we don't have the expertise to approve building plans, nor do I think we
Well,
probably want to be part
Yeah,
of that.
And let me be, this is Laura over here, counsel for the board. So the waiver that's in the regulation as is doesn't have anything to do with approving the projects. I mean, all you're looking at in terms of determining whether or not you're going to grant an extension of time or a waiver of when these requirements under these new compounding regs are going to apply for physical modifications.
But I think that when people submit any type of plan to the Board of Pharmacy and we even remotely look at it, they put Board of Pharmacy approved, Board of Pharmacy reviewed on it, and I don't even look at them when they come to me because I don't want to say I even looked at them. And my concern is this waiver process, we're going to have to look to see that they have some kind of plan.
Right.
So that's my concern,
And the
if we can-
reasonableness of the plan, yeah. And I think it might depend, I mean, it's going to be very fact-dependent and the way that the regulation is currently written. The one comment that I would offer to the committee members is, we do have to be careful about everybody must do X, Y, Z, because once you start doing that, you're back into another reg. So
Right.
really what you're looking at is you're developing your toolkit so that when the waivers start coming to the board, you know the questions to ask to be able to determine, or maybe who, or perhaps the steps that you can take to kind of gain additional knowledge, or maybe help both everybody, all the parties, OSHPD, the board, and the licensees all come together so everybody knows what to expect and, kind of smooth the process out. But I want to be careful about talking about how that if the board was going to approve anything about the plans themselves, because I don't think that's where you're going. You're going to be looking at plans to determine whether or not to grant a waiver.
Thank you.
Yeah, the other thing about what you're saying, I think, and I'm trying not to dredge up all of the exceptions, the people we actually regulate, but that can be gamed a little bit. You can open your project, you can start construction, and then you can suspend construction. So the real implementation of getting this thing online goes farther and farther out. See what I'm saying? Because you can keep a construction project live by working on it once every 6 months.
Okay. I'm not sure. I mean, Laura, I get what you're saying, but my concern is that's not what people are going to assume we're going to do. They're going to send me them, and they're going to assume that they were by the board. And if we can just not even receive building plans, I feel more protected that people aren't going to say that they were reviewed during the waiver process, and therefore we find them in compliance, and it scares me.
And I don't think that there's, the way that the reg is currently written, it has to identify the provisions requiring physical construction or alteration in the timeline for any such changes. So I don't know that the board itself needs to receive the plan, and maybe that's the clarification you're looking for, is that you don't want the board itself, never worked in architecture, so I don't know how intensive those plans are, but I can guess. And I don't think, I see your concern of if you're worried that people are going to actually submit the same plans that they might submit, for example, to OSHPD, that's maybe a clarification that you could put in your, what you present to the licensees, which is you're not looking for that type of detail. Does that answer your concern?
Yes, so I guess as long as we're clear when we do the waiver process of what we're asking for them, but I'm also then unsure how I would know they've actually started the process if I don't have some official document saying the process has been started, such as a building plan, such as a permit that was submitted, something of that effect. So at some point, there's going to have to be a document that couldn't have been internal in the facility that we would have to be able to review to say that they're not gaming the system or, doing something. So that's what I'm
Right.
looking for, if we could get some other way of doing that. And since you have that expertise, I was going to, abuse you.
I mean, I do think that the value of the multidiscipline team observation, I'm assuming you said, I think that was part of the facility staff, right? The hospital staff or the...
Both facilities and OSHPD, like these folks in the second bullet here, the inspector of record is actually hired and paid for by the facility, by law.
Okay.
And then you look at all those other people on the list. Those are, the next three, I guess, the compliance officer, the district structural engineer, and the fire and life safety officer. Those are all OSHPD field staff.
Okay.
And then you look at the architect of record, structural engineer, mechanical engineer, electrical engineer. Those folks are engaged through contract by the client. That's their design.
By the facility?
That's correct.
Okay. So the ones that might be relevant to know, again, to indicate some level of seriousness to effort to comply, once the facility has identified an inspector of record, they've started their process.
Yeah.
Is-
And again, there's supposed to be eyes on the project, making sure that it's constructed in conformance with the approved documents. They don't typically, or they're not typically expected to take on other aspects of a given construction project. Their role's fairly limited.
Just if you can add, who would be the first person that a facility would hire or identify if they were planning a building project?
Typically, the architect of record.
Okay.
Len, thank you.
Sure.
Truly appreciate it. It was a pleasure to meet you as well.
Not a problem.
Okay, we will break for lunch. So what do you think about doing a 30-minute lunch so we can get back? So we'll start back at, let's do 1:45. Thank you. And we're at item C, which is consideration of the process for pharmacies seeking waivers in anticipation of the new requirements in Title 16 California Code of Regulations, Section 1735, 1751. The final version of the proposed regulations that are still pending final review by the department and OL contains a waiver provision for some of the structural requirements. As proposed in the regulation, which is 1735.6F, and in 1751.4L, the waiver request shall be, 1, made in writing, 2, identify the provision requiring physical construction, alteration, or improvement, and 3, contain a timeline for such change. SAFT has developed a proposed process for pharmacies to request waiver. At this meeting, we're going to discuss and refine it. We're not ready yet to discuss the actual waiver form.
I think it's a little early, given what we just heard from Mr. Gall. I think that instead, we need to kind of figure out where we're going to go and how we're going to do this. And the bigger issue is we don't even have a date right now. We're still thinking we're looking at a January date. But I think if I can work on a little bit using OshPod as part of our consultant, we can develop something to bring to the board in July, which would still be 5 months. So,
Yeah, and I think it'd be good to have, to develop a committee or be part of the enforcement committee, something where we could actually review the waivers and have the board actually look at it and make the final recommendations so that we don't put all that burden on staff. Though I think we still need to have staff as very involved, especially, and I'm looking at Christine, she to
That's why we asked
participate
you
in
to
this
come.
review.
That is
She looks
exactly
the other way. Make sure you're actively involved in the process, and as well, I think having OshPod as part of our team that reviews them and participates would be very helpful as well. Any board comments? Nope. Okay. Any public comment? Okay, we're going to move on to, oh, sorry, okay. Good afternoon.
Good afternoon. My name is John Richards. I own a community compounding pharmacy, non-sterile. We've been in a building for 57 years, and I've had 2 companies come out and tell me that they cannot do a negative pressure room based on our building. It's too old. We've got a big giant peaked roof. We're up against a school on our back side, so where it would vent, it would be venting onto a playground, and they're not thrilled with
Can
doing
you
that.
clarify, when you say non-sterile, you mean you're doing non-sterile compounding, like
Yeah,
creams and ointments?
non-sterile, just creams and ointments and capsules and things of that nature. But we do hormone replacement, of course, and that's on the NIOSH list. So we have this handful of things that falls on the list. Other things, of course, do not. But I need to know, that's what I came today, was to see if there's a waiver in place for something like me. I mean, I've heard the hospital side of it, and I know they have but I just signed a 3-year lease about 6 months prior to this all coming out. And I am in that lease, and so I need to, not only that, but I need to move to a new building anyway, so I need to move, but, after the lease runs out, obviously. So I am kind of stuck into this little tiny corner, and I want to do what's right, and I totally understand why we're doing this and why we're moving forward with this, but I just feel like I'm pinched and I don't know what to do. And how does a situation like mine, I got to figure I'm not the only one in a super old building or is next to a school or something like that, where you wouldn't necessarily want to, if the whole idea is to not be aerosolizing things, to aerosolize it onto a playground or something. So I was just wondering if there was a situation for me, is it a waiver, is it what?
well, the difficult answer is you're not asking for a waiver. You're asking for a blanket exemption from the requirements.
Oh, no,
As long as you're in your current location for 2.5 more years. So I don't know how the board is going to view that. They're going to have to determine whether or not there's a way you can comply with something less than structural build-out. Can you do it with isolator units? That's something the board's going to have to decide how it deals with that.
Yeah, I mean, I
I'm
have
assuming you've tried the
ductless-
isolator units
I have
already.
ductless hoods right now. I mean, everything's done inside the hoods and.
If you
I
get an
mean, you
isolator,
know.
I think he needs to have a separate room also for,
That's what, and that's what you're requesting really is what is it, the ISO 7? Is that what it is, an ISO 7 room?
So the
That's a
ISO
negative.
classification is only needed if he's doing sterile, but the pending regulations will actually require a separate room that is similar to a clean room, as in it has to have cleanable surfaces, it has to have negative pressure. So in the current regulations, I'll look again, but I don't think an isolator would meet that requirement, but he is definitely not going to be the only one in this situation. So just, we have to kind of keep that in mind as we try to figure out what our plan is.
let's review it and see what we can do with an isolator, because that is a contained clean room. If it's, you're not doing, you're just hazardous, it's just hormone
Yeah,
replacement.
hormone replacement, yeah. And so, like I said, I'm willing, and if I have the date that my lease is up, and I will be looking and trying to get into a spot. I have a place that I've been looking across the street that's, buildable. It's completely buildable out. It's gutted right now. I want to do the right things here, but I can't just destroy my asset here either and just say, just walk away from it and go, okay, well, there goes my pharmacy. I mean,
Well, I don't think
You know,
that's
I
what we're
mean-
asking at this point. You may be in a difficult position right now. I think we're going to be in similarly difficult positions for some pharmacies in this state.
right.
So, I don't know.
I think there's an answer. The regs aren't even, we don't have a date when they're going to be really official, because we heard today that they
Right,
may not be
yeah.
ready to go
Right.
by January, so that may buy a little bit of time.
Right, okay.
But you may want to still be looking for options.
Oh, no, I have 2 real estate agents currently looking
Wow.
for spots. I mean, I'm trying, I've worked with the landlord, see if I could sublease, see if I could this, see if I could that, but she's just, nope, sorry, hey, you signed the lease, not my problem. And I just, I'm a small independent business. I mean, I can't really afford, I'm not a CVS or somewhere where I can just eat a lease for 2 years and go, oh, well,
Yeah,
price of doing
well,
business.
Let's see what options we have and what we can develop.
Okay, all right. Okay,
Thank you.
Thank you.
Any other public comment? Okay, we'll move on. I think Christine's got a presentation we're going to move to, which is a presentation on the overview of compounding inspections that are performed and violations noted. So it's item F on the compounding agenda. I moved to, I got to see this one.
I'm going.
Okay, so I have kind of tweaked the presentation just a little bit because there's a lot more data on the back end of where our inspections are leading to now. So I kind of feel like that's more helpful for you to see versus just what we're seeing on inspections. So what I have is almost a year's worth of data, so there's a lot of numbers in here. So this is from the beginning of the fiscal year through about the 13th of last month. So on the 17th of last month, we had 929 LSC or LSE. So the LSE is the fee exempt and the LSC standard, and then the NSC is 96. So that's how many licenses we currently had. The numbers kind of fluctuate back and forth, but it's always about the same, 900 to 1,000 LSC and somewhere around 100 NSCs.
And that includes hospitals and,
Yes, so the LSC, LSE number will include hospital and PHYs. Yeah, it's very difficult to break all the numbers out into the type of sterile compounding because we actually manually have to do that because our licenses don't pull like that. All right, so the total number of inspections done by the inspection type. So when we look at the LSC inspections, we have to inspect every time one is renewed, so yearly, and we have to inspect each time one is issued, so that would be our new. So those are the 2 types that we're doing at this point. If you have a change of ownership, a change of location, or you did some type of remodel or renovation, those fall into the new category. I really think that the new category is going to become more and more and more as people start doing renovations. And we do inspect even if they put in a new hood or something like that, because we have to make sure they're compliant. So 927 renewals and 94 new ones were done during the time period. And then this kind of breaks out what type of facilities we went into. So these are the total inspections done by pharmacy type. So the 503Bs, we did 25. The central hospital packaging license, we did 2. I think that's somewhat misrepresentative because we hadn't issued all of the CHPs. Some of them were opening, so they fell into the HSP category. So there's,
And
I think
CHP is what?
the central hospital
Oh,
packaging.
the central, okay.
Yeah. So some of the 564 HPE, HSP are probably, because I think we have 7 or 8 CHPs now, probably in that category, but it's hard to draw out whether we were there for new or renewal for some of the facilities, because we have more than 2, and I know we inspected more than 2. The licensed correctional facilities, we did 4. Non-resident pharmacy, which is the NRP, we did 66, and then pharmacy, the PHY, we did 360. So that gives you a general sense of more of what we're actually looking at and what we're inspecting rather than the raw numbers. Go back.
Yeah, I'm just wondering.
NRP 66.
What percentage is that of the total NRPs at Deuce-Starrell Compounding?
That's
That's
100%. They can't ship into the state unless we've inspected.
So there's about 66?
During that time frame, that's how many we had inspected. There's, if you go back, there's about 96 licensed as of 5/17. But during the time frame that I looked at, we had only done, I skipped ahead. We'd only done 66 during that time frame. All right, so then we looked at the violations by license type. So what you have to keep in mind is while it looks like there's a lot more hospital violations than pharmacy license, you have to remember 2 things. We did a decent number more inspections, and there are a decent number more licenses. So the way the LSC is broken down, one hospital permit can have 4, 5, or 6 LSC permits because the LSC is by location, whereas the hospital can be the whole building. So the violations found by license type, we had about 650 for hospitals, 397 for pharmacies, 85 for non-resident pharmacies, 15 for 503B, and 15 for licensed correctional facility. So then I broke it down into the top 4 or 5 or more relevant violations by license type. So for the hospitals, we had a total of 650 violations found on inspection. 84 of those violations were 1735.2. Within that subdivision of those 84, 38 of those violations for not having a master formula. I can tell you this is the 3rd or 4th time I've done this, and this is probably number 1 on all of them. We clearly need to educate what our expectations are for the master formulas. The next one, which I just cannot understand for the life of me, is 12 violations for still not having completed the self-assessment. It's
Are these just smaller hospitals, or?
I don't have it stratified to that because there's no way for me to tell how many beds there are. And when we did, 500 inspections, I didn't go one by one. Jenny?
And what is the typical consequence? Are we now citing and finding for these violations? Or are we still doing a diversity of options depending on what we find?
If it was noted, either a discussion point, a correction from the year before, it absolutely is a violation at this point.
So we're citing and
Yeah,
finding at
and
that
we're
point,
still-
which is what I've been saying.
Absolutely. We're still finding that the people that aren't completing the self-assessment are much more prone to larger violations, like what's a master formula, what's a compounding log, I need training. If you don't read the document to lead you down the right path, you tend to lead down the wrong path. So again, still 12 of them. Yeah, it's a lower percentage, but this should be pretty basic that they can remember to do that. And then for my hospitals, we had 70 violations for facilities and equipment standards. 40 of those violations for cleaning not being done on the correct schedule. So 1751.4D requires a weekly cleaning protocol. I have 40 hospitals that are not cleaning on a weekly basis. Let that sink in. 40 hospitals that aren't even cleaning on a weekly basis.
And when you say not on the correct schedule, if they go a day later than the weekly schedule, or are we talking about actually not cleaning?
I think we're a little more flexible than that. What is happening is there's a slight differentiation between USP 797, which is a monthly cleaning, and us, which since 2010 has been a weekly cleaning schedule. I have 40 hospitals that haven't caught up since 2010. These are becoming violations because it's not acceptable. And most of them we have already asked for compliance and educated. And it's just taking time to do that. And then we have 12 violations for all the equipment used not made of material that is easily cleaned and disinfected. I kind of highlighted this process, and it kind of helps me that Oshpod was just here because one of the building codes that we use is the 1250, and it relates directly to this. We're finding plywood, particle board, all these things that don't belong in a compounding space still. We're finding people taping things to the inside, the outsides, or the top of their hoods.
Do we know when we look at these whether they're repeat violations or they're first-time finding? Because we're doing annual inspections. So these what you're citing right now are violations or standards that have been around for a while. They're not new. So do we say, okay, this is a second year in a row or a third year in a row, or is this the first time we're finding these things?
It's hard to say with the number of violations. I had to look at 650 of these, but I can tell you at the end, those next couple slides, when you see where we're going with stuff, the numbers of those are going to slowly increase. And I think as we have our meetings, I think that data is going to become more informative than the actual raw violations. Because when we issue something on an inspection, it could just be a correction. We're like, hey, you know, come over here. We're in compliance over here. Let's lead them where they need to be. And it's still going to list as a violation because we noted it. But what's going to end up happening is you're going to start seeing our cite and fines going up, or you're going to see our referrals to the AGs going up, or revocations or cease and desist, because we can only ask them so many times to come in compliance. As far as how many of these 12, I don't have that information because too much data.
But generally, before the inspector goes out, we expect them to do some legwork in advance. And one of the things that frequently are accessed is the prior inspection.
Absolutely.
And who did it.
Yeah.
So let's say that they find a process where all equipment utilized is not made of material that's easily cleaned or disinfected, and it is a new finding, and it wasn't found the inspection last year, and nothing's changed. Are we educating the inspectors to make sure everyone's up to par on the same level?
I think the attempt is definitely to keep everybody on par, but I think each inspector has specialty and they have different training, and sometimes you're going to walk in a facility and you're going to be distracted by what's over here, and you're going to spend your 6-8 hours over here, and you're going to realize at the end of the day, I never looked over here. So I think that we're trying to, and I think that a lot of the materials that are being used in facilities is really coming up in our discussions, because you can look at a nice table like what I have in front of me, and nobody realizes underneath it's completely open particle board until somebody happened to bend down, they picked up their pen or something, and oh look, the whole cupboard underneath my hood is particle board. We absolutely look at the inspections the year before. We're now, especially for the 503Bs, looking at all the 483s. There's a tremendous amount of reading before you even get to go into a facility. Sometimes we have to reach out to another inspector, sometimes the FDA, sometimes CDPH. Yeah, we're trying to be more consistent, but, there's a lot of these to look at. All right, so the next one is 66 violations for not having all the required compounding records. 31 of those violations were for not having or having inadequate formula or compounding log. So 1735.3A, again, has been around since 2010. It's been modified slightly. We removed the equipment from it, put it to the master formula, it came back, and then it went back to the master formula. But in its current form, it's pretty much been there since 2010, but we're still not getting a whole lot of compliance with this. I think a lot of people are going to really struggle with this with the new regulations, because the new regulations require the same items, but required in one document. What we're having now is we'll ask them for a compounding log, and they go into whatever data they have that's like snapshots of the compounding process, and they're trying to give us 40 or 50 pieces of paper for 8 items. So I think that we're going to see that one jump significantly. I think that's something that we're definitely educating on, but I think it's going to be a struggle still. So 53 violations for inadequate quality assurance plan. Two main ones would be not having a written quality assurance plan designed to monitor, ensure the integrity, potency, quality, or labeled strength, and then 11 violations for written standards of the qualitative or quantitative methods. And this is something that's kind of in the work, and we're doing a lot more education on this because I don't think people really understand why it's needed, and it's not necessarily always a measure of the product you're looking at, it's a measure of your process and your state of control in the facility. And so a lot of people are still struggling with, well, why do I have to spend the money? Well, in the next set of regulations, it's going to be required at least annually, and we've been trying to educate people, yes, we're requiring it annually, but do it so you get some use out of the data. All new employees, once a month, one type of drug. Do something so that you get use out of the data. If we required it a certain time frame, more than a year, it would be difficult. So this is the one that I like that Oshpod brought up. So the 1250.4 is the building standards that he was just talking about, and we had 33 violations for that, them not complying with the building standards, and the building standards are pretty basic, like he said. 15 specific violations for not having non-porous and cleanable surfaces. So 15 hospitals still had non-porous, non-cleanable ceilings, ceiling tiles, floors, walls, or floor coverings. So it's an old standard, but we haven't gotten there. So I think we have a long way to go.
Given that this is such an old standard, and we've been finding this, are we doing any cite and fines on these?
Yes.
Or
That one is now, especially it's been noted before, I've seen a couple that have been noted for the ceiling tile. I've seen a couple where the work surface in the
The hood.
hood is fiber.
It's particle board, and it's laminated, and it's so old that the corners are chipping, or the laminate's just coming off, and you can see the particle board, and that's the deck of the hood. I've seen rust. We've got multiple facilities with rust in the hood. Sometimes it's right in front
That's
of
frequent, yeah.
the compounding surface, so it's the HIPAA filter that blows out. There's a surface with rust, and then there's where they're compounding. It's not okay. Those are automatic violations. And the issue is then we can't renew because they're clearly not in compliance, and then they kind of had to scramble and figure out what they're going to do, and it does cause some heartache. It becomes very stressful, but in the end, that's the job of the PIC. They need to be in there on a daily basis and see what's going on with this stuff. A lot of these are becoming violations and causing a lot of heartache, especially in the hospital world. All right, so on to pharmacies. We found 397 violations, 50 of those violations for, what do you know, not having a master formula. 5 of the violations for not having a self-assessment. Similar percentage of what we found in the hospital. So clearly, master formula is number 1, pharmacy and hospital. So I will educate you at the end on that one. All right, pharmacies, 43 violations for not having adequate quality assurance plan, 9 for the same issue that we found in the hospitals for a written quality assurance plan, and then 8 for not having the written quality assurance plan, including written standards. Same 2 violations came up. I think they were number 3 in the hospitals and they're number 2 in the pharmacies. So this is a little bit different. This didn't come up in the hospital so much, but we found 38 violations of 1751.7, in particular 13 violations for not having or having inadequate process validation for sterile compounding staff. This comes up when somebody is doing a higher level of compounding, say they're doing high risk, but they never thought about it, and all their process validation, so their PAT tests, their media fill tests, are for lower medium risk. Well, clearly that doesn't certify you to do the level of compounding that you're doing. Most of the time, this has become just the starting point for a large investigation, because if they're not paying this much attention, probably all 13 of these become a case. And then 8 violations for not having or having an adequate sterile quality assurance plan. These kind of run the gamut. It can be just they don't have one, they didn't have an adequate recall policy, all over the place, but they definitely have room to grow in our quality assurance plan for both sterile and non-sterile products. So here we go again, not having compounding records. So 36 violations for not having compounding records, in particular 26 violations for not having or having an inadequate master formula or compounding log. We're struggling even outpatient to get them to have those compounding logs when we set the bar even higher when the new regulations come out. So I see we're going to have a lot more education with this, especially when that compounding log has to be on one document. And here is my 1250.4 friend. Even on the outpatient premises, we found 16 violations for them not meeting the building standards. 8 of those violations were for having not having non-porous and cleanable surfaces. So at least 8 facilities that we visited that were doing outpatient dispensing did not meet those standards. And to me, this is a little more concerning because most of my hospitals are not doing high risk. A lot of the pharmacies are doing high risk. And if you think about it, they're doing non-sterile to sterile, and the environment they're doing it in does not meet the minimum of the building standards. All right, long-term care facilities. We only did 4 inspections, so licensed correctional facilities. There's not a whole lot of these in the state, but we did find 15. 2 violations for not having compounding logs, 2 violations for having inadequate policies and procedures, and then 2 more for a quality assurance plan. So it's very similar to what we're finding in all the other facilities. 503Bs. So a reminder, 503B is registered with the FDA as an outsourcer, so they can do non-patient specific. Basically, they're a mini manufacturer. Under FDA regulations, they fall under CGMPs. With us, they are currently licensed as a pharmacy, and we found 15 violations to our regulations. Just imagine what's going on with CGMPs, which is a step above that. So we found 3 violations, one for not having adequate sterile quality assurance plan, and I can tell you this particular one was because they were doing high risk, and they didn't have the PAT test to do it. So they didn't have the process validation for the staff that was doing high risk, but yet they were allowing the staff to do it.
And this is a pretty serious, I mean, this is an entity that holds itself above a pharmacy.
Correct?
So, and they're having these kind of issues.
Yep.
Are we doing anything about?
Wait till the end.
Okay. All right.
Yeah, no, most of
I just got hit with a question, I didn't know the
Yeah,
answer.
no, most of the time when we walk into a 503B and they're not meeting our minimal requirements, it's an issue. Some of the 503Bs that we went into some of them could have been because we received a 483 from the FDA or because we did a joint inspection with the FDA. But most of the time when the FDA goes in and they hold them to those CGMPs, they're so far above where our regulations are that it's really hard for us to reach them. So I think it's very concerning that somebody that's mass producing a drug did not have, they had inadequate quality assurance plan, or they did not have proper process validation.
These are basics. This is basic
these are
for sterile
basics.
compounding.
Yeah. And then the one violation for not having documented end product testing is an AG case, and it's going there. So we're holding that one accountable because they're no longer doing that. All right, so 2 violations for not cleaning on the correct schedule. This is an issue, but it's more because we are not in the same schedule as 797. When you look at the 503Bs, and especially ones that are out of state, they tend to follow the national practice standard, even though they shouldn't be doing 797, they should be doing CGMPs. Most of them end up cleaning monthly. And so then we're like, no, you have to clean weekly. But this is going to change. The pending regulations changes back to the monthly, so that this one should go away. And then only 2 for not completing the self-assessment, but only 2 of, how many inspections did we do? No, I think we did, hold on, it's in front of me. But we really have been trying to educate. So 503Bs, we did 25. We did 25. So it's not too bad. It's probably not any better than the percentages of the hospitals or pharmacies,
About
though.
10 was
Yeah.
20.
All right, so outcomes. This is where I kind of want to focus more because we're doing the inspections. We know we're doing the inspections. We're doing a lot of them. We're writing a lot of stuff, but this is where we're going. So in the same time frame, we issued 2 cease and desists, 1 to a 503B and 1 to a hospital, and then we also received a written voluntary cease and desist from an in-state sterile compounder. We referred 15 LSCs for formal discipline to the AG's office, and we also referred 3 NSCs. So
Are all
we're getting
these
there.
in state?
The LSCs are all in-state, the NSC is out of state.
And the 503Bs?
I didn't stratify them to that. I believe at least one of the NSCs, one of the NSCs is a 503B. But they probably won't be by the end, because I don't think they qualified to meet all the things. They'll probably drop down. So we also have been conducting quite a few joint inspections, so I just wanted to list that we've gone out with the FDA 5 times into pharmacies and once in a hospital, and we did accompany CDPH at 1 hospital inspection. So we're trying to be more consistent, because even when we go out with CDPH, we have different focuses in a hospital, and when we go out with the FDA, we just have different focuses altogether. And then, so these are the outcomes from the Attorney General's cases. So these tend to be the cases that were started a while back, and these are the outcomes we're getting back now during this time frame. So we had 1 voluntary surrender of that one was a 503B. We got 1 public reprimand, a 503B, 1 for an NSC, and then we put 4 NSC or LSC, so in-state pharmacies, on probation, and 1 NSC on probation. Don't think the probationer is, no, they're just a pharmacy. The NSC is not a 503B. And so as of 5/17, we have 6 LSCs on probation and 1 NSC on probation. And here's my education. So currently, well, as you can see, the master formula is something that everybody seems to be struggling with. The verbiage in the pending regulation still requires the same items. The only thing it's going to require is them all to be on the same sheet. So we are asking for a master formula to be done prior to compounding. It has to have the active ingredients, the equipment used, the expiration dating requirements, inactive ingredients, process or procedures used, quality reviews, and post-compounding process if required. It's still something that people are struggling with.
So what's the expectation? So I'm making a Zosyn piggyback. What equipment do I need to list on there? Do I need to go down to the point of putting the syringes and the needles on the compounding formula? Or what exactly is referenced by equipment?
At minimum, I need to know which hood you're going to use it in, because hoods have problems. So that's why we talked about the equipment. It went from the compounding log to the master formula to the compounding log, because the issue is some facilities don't make one type of drug in one hood. But I need to know what hood it is, because sometimes hoods exceed the CFUs that they're allowed. Sometimes they have to be renovated. Sometimes we need to know what it is in case there's a need for a recall. I personally prefer if they give me the syringe, but it doesn't do me any good to tell me you're using a 5 ml syringe if I don't know what lot it is. Because if there's a recall, saying you're using a 5 ml syringe doesn't do me any good.
We're requiring for a lot number of syringes?
Not normally. Not normally. We're not asking them for that level. So we would need to know where it was made, if you used a repeater pump. If you're going to use, so if you're making a Vanco, are you going to dilute the 10 gram? You're going to use sterile water? You're going to use the right volume of sterile water? The equipment is basic.
Well, sterile water I consider a component, not an equipment.
Yeah.
I'm just referencing the equipment. So
But it's the master
it's basically
formula.
the hood.
So your sterile water would have to come under number 5.
Yeah.
So you would need to tell me that you're going to dilute it with the appropriate amount of sterile water.
Right. That makes sense.
All going to be in there.
But the equipment's basically just the hood that you're using to identify the hood.
Or if you're using any specialty equipment. So
Okay.
do you use a repeater pump to make it? Do you guys use I don't know, there's all kinds of
Or
things
an
they can
automated
do.
mixer or something.
Yeah.
Okay.
The basics, so we can follow that.
Okay.
It's really where we see people failing is the process and procedures and the post-compounding process. So it's 5, 6, and 7 that people just kind of get sloppy with. They say, draw up correct volume, put into correct volume of large volume. And they don't tell you what it was diluted with. They don't tell you how it's diluted. Vancomycin is my favorite. Everybody gets those ginormous 10 grams, and it was diluted. No, you need to put where's Peg? 20 mLs, right? You need to put the full 20 mLs in there. The manufacturer did the FDA approval, dilute it with 20 mLs, wait for it to dissolve, and then you can draw out your appropriate amount. We're struggling because people don't tell that, and each technician does what they want to do. And then we have an issue because if you don't dilute it correctly, it may fall out of solution. So we need the master formula to make sure that there's a level of control in the pharmacy. And then the next issue is making them read it. Because a lot of them, especially in the hospitals, I find nobody even knows where they are. Because everybody just does what they want. Well, this is how I've always done it. And that doesn't really give the level of control that we need them to have. And then the quality reviews, such as we checked for precipitate. We made sure the bag was not leaking. Post-compounding process, I labeled it refrigerate, put it in an amber bag. Things like that. For non-sterile to sterile, we would expect what sterilization method was used, what tests need to be done after it. So if you're making a non-sterile to sterile, we use filtration. I use this type of filter. We then did a bubble test. The bubble test, you need to tell us. And then it's sent off for whatever testing. That's your post-compounding process. It's pretty specific. So if I go into your pharmacy, I can make what you made the same way you made it. That's what we're asking them to do. And I know for the hospitals, it's very labor intensive. But most hospitals make 30 to 50 different drugs on a regular basis. So it just takes somebody to sit down and do the 30 to 50 drugs, and then it's done. And then somebody to keep up with it. That's all. What else you got? All right.
Thanks. Any questions? Alan? Thanks, Christine. That was really informative. Any public comment, any public questions?
Hi, Christine Verskell from Dynalabs, and I brought my new troop here, Ryan Flint. He works for Dynalabs, and he's working with me on in the West region, and we're particularly focused on California. He's a microbiologist, so he knows all this stuff. One of the things at Dynalabs, when we first started working with California pharmacies, is we noticed that they didn't have formula worksheets. A lot we require them when we do testing. So just so you know, we pushed the fact that they should send a formula worksheet with the compounded drug that they send for us to test. So I know that you have in 1735.2 requirements for the master formula worksheet, but do you have an example of that? And I should know that, but my computer died, so I didn't know if you have an actual example of a formula worksheet or a master formula worksheet within the regulations.
We don't have a mock copy in the regulation, no, but we have the component, but we do have the components we expect to
okay.
see.
So what we'll do is on our end, make sure that they understand that if the formula worksheet doesn't have those components, that it should have those components. So
There goes your business, thank you.
And I think Christine made mention that the new regs will have it all in one sheet. So they might as well get used to doing it that way.
Okay, so we'll press on that. So good. The other, do you want to talk about?
No, just to go with the master formula worksheet, is that if there were to be an adverse event, it really helps to know the pinpoint where your issue may lie just looking at your master formula. If it was supposed to be a refrigerated product and you didn't mark that as refrigerated and kept it at room temp, it'd really just solve all of your issues maybe right there.
Thank you.
Thank you.
Any other public comment? Hi, Lynn.
So my question has to do with which hood, because My understanding of the master formula was that it was the type of hood, so that if you have a clean room with 3 or 4 laminar flow hoods, there's not normally a delineation. We do drugs A through C in hood 1 and D through, they don't get sorted out that way. So I guess the specifying which hood should probably be specified in the language of the equipment.
Are you saying you have 5 laminar flow hoods and you name 1, 2, 3, 4, 5, and so it's to your benefit to identify what hood everything is compounded in, especially for recalls, because if you have one hood that ends up out of specification or accidentally got turned off, you must recall every product if you don't know where those products were compounded in. And surprisingly, hoods get turned off a lot. So that's why I really suggest that you find a way to know where everything was compounded. If you don't want to put it in your master formula and you just want to say that it was compounded in a laminar flow hood, I agree the regulations don't specify it to that level, but when we come in, if there's a recall and you can't identify that, we're going to expect you to have recalled every sterile product that was made in that
Well, you know
facility.
who made it, and you know which hood each person worked in, so you could.
If they stay in the same hood.
But that's the thing, like, so,
Well,
but I still don't think that's specific enough, because do you assign, so from an investigation standpoint, when I collect those records aren't going to identify, they'll identify the person who compounded it and they'll identify the person who verified it, but will they identify even in your personnel record what hood that person was assigned to that day?
Of course, because they had to clean it.
That person, so in my experience, when I go even into bigger facilities, one person is cleaning the entire clean room when they come in, or they're cleaning all the hoods, or, so that's the thing.
That would
It's
be a
long,
different way to do it.
yeah, I
But-
guess it
but
depends
I would
if it's
say-
trackable.
I would say there's nothing currently in that language that would cause me to know without your explanation that I'm to identify which of the laminar flow hoods.
And I would say that it's more particular, but why I'm looking for it is because if you need to identify it in an issue, that's the whole record keeping requirement is if something happens, can you protect the public from unforeseen
I
things?
understand
So,
that.
no, but I would
Okay.
agree with you. I don't think there's anything that says which type of hood, but I think you must list the equipment. But I think you're kind of, the difference between the type of equipment, I think is kind of leading into the process validation, where that one says the type of equipment. This one just says equipment used. It's much more broad. The type of equipment is from 1751.7 when it says the type.
I wasn't aware that the equipment referred to which laminar flow hood, so I think maybe we need to do some more education on that as well. I don't know, were you aware?
Not a clue.
That's the first I heard of it, so it would probably be good to let people know that that is our requirement
Yeah.
and have this out maybe on could we maybe have on the next script?
lot of people that
an
don't know
overview
that
of the master formula and what the requirements are, so that we can do an article for that?
No, as I'm looking.
Sure, I'll do it.
I remember this came up. I remember this did come up with a prior supervising inspector who's no longer with us, and that was a very strong point of contention for him, that we noticed that. But I don't see a specific requirement, it just says the equipment to be used. It doesn't say with specificity down to which one of the balances you use or which one of anything else you use.
Agreed.
Good afternoon. Can you have is the green light on your microphone?
There it goes.
Okay.
So I just wanted to, you mentioned some hoods, I'm back on hoods, some hoods are made with particle board tops. So is it the particle board Formica that's the problem, or is it that the Formica on the edges was damaged?
The lack of maintenance in the Formica, whatever, the laminated on top of the particle board. A lot of times we go in and it's chipped in the corner or in the middle, it's
Okay.
split, and we see everything from caulking to clear plastic tape, trying to fix it, but not repairing it up to manufacturer specifications. So that's
So it's-
usually what happens. Or sometimes it's just been cleaned too much and it's just worn down.
So Formica is okay. But-
Non-porous and cleanable.
Okay, gotcha. Because stainless steel is a much better option, but
Yeah, well, can I add to that? Because
Don't
what
get
we're also
scratched.
finding is the top is laminated, but underneath is not. So the particle board underneath is completely exposed.
I see. So that's a bad situation. So if it's manufactured that way, that would not be an acceptable hood.
Yes, if only the top is laminated and the bottom, the particle board is all completely exposed and not washable and it's porous.
You're with Baker, manufacturer of laminar flow hoods?
That's right, yeah.
How many of your laminar flow, just out of curiosity, do you make that fall under where there is open material? Is that common with laminar flow hoods?
Open
Where there's
material.
porous material, like open, like what she was referring to underneath the counter?
Well, that's the reason why I'm asking the question, because the ones that we sell don't have anything. We don't have any particle board in ours. One of our competitors does. So that's why I'm kind of asking to
Wow.
understand that
Okay.
situation.
Yeah, most
So-
of
It was
the hoods
worth
we're
coming to the
seeing-
meeting, wasn't it?
Exactly.
Most of the
Okay.
ones with this problem are 20 years old.
Okay.
And it's time to lay them to rest.
Or they might buy a freestanding one and just put it on a table of some kind?
There's every scenario.
I'm going to recommend that the committee kind of focus back on the agenda. I believe you're on 4F, right? The overview of the
Yes.
compounding inspections and violations noted.
Right, well, I think she found some equipment violations, and that's what we're referring to. When we're talking about the hoods and the particle board, that was part of Christine's presentation. So we're just elaborating on that. Thank you.
Thank you very much.
Any other public comment? Thank you, Christine, very informative. Going on to item D, consideration of the Pew Charitable Trust reports, best practices for state oversight of drug compounding, and national assessment of state oversight of sterile drug compounding. Recently, the Pew Charitable Trust published reports on the best practices for drug compounding. The goal of these reports is to establish a baseline describing state policies today and promote best practices in order to ensure that patients are safeguarded regardless of which state they receive treatment. Attachment 9 contains a copy of both reports, and Executive Officer Harold served on the task force representing the board and California and participated in this. Jenny, anything else you want to add?
No, but if you want to read them, I just happen to have the copies in addition, if you prefer to not read them. I don't know what
California had
I'm doing.
had input into those reports.
Well, right, and that's one of the things, we were one of the first states to jump out after NECC, and we were also mixed in with a couple of other large states that were involved, and that they're looking at how they're going to regulate compounding pharmacies, at least back in 2014 when this started. So they are now looking at trying to do the outsourcing nationally through some oversight, and again, they're looking at the larger states in terms of what we're doing. So we'll see where this goes. Unfortunately, when we developed these, though, a lot of this was done before we had outsourcing. It had been brought up, but they hadn't really fully rolled out the outsourcing to the degree they have now, because a lot of this work was done in 2014. But it's there if someone would like to read it.
Thank you. Any board member comments? Any public comments? Good afternoon, Dr. Cotman.
Marie Cotman, speaking on behalf of myself, and Jenny, I want to say that this report is fabulous. It's got a lot of great information in it. I have read through it. But I have a question for the board. If this is going to be the way that we hold the standards high in the practice of pharmacy, and pharmacy is really the ones tasked with doing the compounding, are we going to be holding our colleagues in other professions to these same standards?
That's going to be up to the FDA.
So
The
the
FDA
FDA's
is going to have to
and the medical
enforce
board,
against,
right?
yeah, they're going to have to enforce against physicians. The veterinary board has requirements currently pending in California that are similar to our requirements for vets. Right. They're a little more restrictive, but in the sense that only a vet office can do compounding for its own patients. It can't dispense like a pharmacy would, but they're not dispensers, they're prescribers, so. But the physicians are a unique rule unto themselves, and the FDA, to my knowledge, has not gone to the physician side of compounding yet.
Okay.
They're talking
Your
about it.
comments are related to physicians.
Actually related to, there's several other practitioners out there, chiropractors, physicians, pharmacy technicians that aren't licensed but are out there labeled as pharmacy technicians
That's
that we
physician
see on the
practice,
front line.
Yeah.
So I was hoping that this board might, is it appropriate at this time?
I don't know, Laura, can we talk about that?
So, I mean, I think you can talk about it insofar as if whether or not it's a topic you want to have later, but if you're talking about a specific case where you think that you're going to file a complaint or that a complaint
Well, I
has
wasn't
been
going there.
okay, then I would recommend it not be presented to you because it sounds like at some point in time, it could be presented to you in a different format. So.
Okay,
I'll
thank
fill
you.
them in. Thank you. Item E, consideration of the FDA's guidance documents on standards for compounding drugs under 503A and 503B of the Federal Food, Drug, and Cosmetic Act. In April 2016, the FDA released three draft guidance documents for public comment involving compounding or outsourcing of human drugs. Each of these documents is listed for discussion at the meeting. The board may choose to submit comments, which would be due by mid-July, which is before our board meeting, right?
Right.
Or on some or all of these guidance documents as the FDA develops policies for compounding and outsourcing facilities in the United States. The first one is the prescription requirement under Section 503A of the FDA Federal Food, Drug, and Cosmetic Act. And according to this guidance document, compounding after the receipt of a prescription for an identified individual patient. This is what this guidance document addresses. Compounding before the receipt of a prescription for an identified individual patient, which is anticipatory compounding, and compounding for office use. The guidance document states that the value of compounding for individual patients by pharmacies, outsourcing facilities, and physician offices when clinically necessary for a patient. The FDA states that when a product is compounded by a pharmacy or physician for an individual patient, the compounding entity is usually not registered with the FDA, and that the FDA is not usually aware of problems with compounded drug products unless it receives a report of serious adverse events or visible contamination. The FDA states it has identified many pharmacies that compound drug products under unsanitary conditions and shipping numerous products, sometimes in large amounts across the country. The longer compounded sterile drug product that has been contaminated is held by a pharmacist or physician before distribution or held in inventory in a healthcare facility before administration, the greater the likelihood of microbial proliferation and increased patient harm. As such, the FDA states that compounding by 503A pharmacies necessitate the following tenets. 1, compounding is for an identified individual patient only after a patient-specific prescription is received. 2, drugs compounded in advance of receiving the prescriptions are compounded only in limited amounts for anticipatory compounding. And 3, drugs are distributed pursuant to a patient-specific prescription. The guidance document encourages the use of the following statement when a prescriber is prescribing a compounded drug product for a patient. And that states per type of communication with the name of the prescriber. So per this communication with Dr. Jones on June 1st, Dr. Jones has advised that compounded vancomycin is necessary for the treatment of Mr. Jones. The guidance states that unless anticipatory compounding is done for a limited quantity of compounded products, a prescription for a specific patient is first required before compounding occurs. So there's a list of items when anticipatory compounding can occur. First of all, based on the history of the licensed pharmacy receiving a valid prescription order, if the orders have been generated solely within an established relationship between the pharmacist and the prescriber, the compounder holds for distribution no more than a 30-day supply, and the amount of supply is based on the number of valid prescriptions received by the compounder for identified individual patients in a 30-day period over the past year. This sounds similar to some of our office compounding guidelines.
A little bit. This is a little more restrictive. The 30-day is far more restrictive than ours, which is kind of open-ended. And again, it's, you shall not dispense until you have a prescription in hand, is what it is for 503As, which is what they're really telling you.
And they're really, and is this for in-office use? Because
In-office use can go to prescribers, but it's got to be limited. If you're going to compound in advance, it's for a 30-day supply, and if you're giving it to a physician, I believe the compounder holds for distribution in more than, wait a minute, if the orders have been generated solely within an established relationship between the pharmacist and the prescriber, based on the pharmacy receiving a valid prescription order. It ties back to the prescription. So it doesn't specifically say that the prescriber's got to provide the pharmacy with the prescription in advance or even after the fact, but I think that's kind of what they're getting at. Christine, we've seen the FDA go into a couple 503As, and we see them looking at the anticipatory compounding piece in particular. Is there any comment you want to make on this and what we've seen with the FDA? I'm aware now of 3 pharmacies in California where they've gone in and looked specifically at a 503A.
Yeah, so as soon as they see any office use, doesn't matter what it is, sterile, non-sterile, 2 prescriptions, they don't consider them to be a 503A. They are now a 503B, and they're held to CGMPs. I haven't seen any even inspection to 797 standard, because everywhere I've been, they've always held them to CGMPs. As far as the anticipatory, I think that they do look at that. Depending on the volume they're doing, they will judge whether they consider it compounding or manufacturing, but.
I haven't seen it linked, though, to having a patient-specific prescription on the premises of the pharmacy at the time they've gone in, though.
I don't think they look at that detail.
Well, I think they might be planning on it, but, yeah.
My understanding of this is that they don't want any office use in a 503A. That's my understanding of what they're saying.
they wanted to go more to the 503B.
Correct, that they don't think it belongs in a 503A because it could affect more persons than that one person that patient-specific prescription is for. They want to push all of that non-patient-specific compounding or outsourcing to somebody under stricter regulations. So this
And California is not the only state where we've seen the FDA go in and do these inspections either. I've talked to other states where they're also seeing the FDA going into 503As. And they're doing it under their insanitary condition provisions.
Any board comments? Public comment? Okay, moving, oh, sorry. Good afternoon.
Hello, my name is Sarah Wallach. I've been in compounding for a long time and most recently have spent the past 2 to 3 years at a 503B facility. I just want to say that I have seen the FDA citing quite a few warning letters to 503A facilities over not having patient-specific prescriptions. They are citing for any kind of non-office use. And then I was wondering, with the new draft guidance, I know that guidances are not legally binding by the FDA, but they do represent the agency's current thinking on a topic and is usually in the best interests of the pharmacy to follow those guidances, not to get in trouble with the FDA. So I was wondering how that is going to affect the 72-hour rule that's normally allowed by California Pharmacy, Board of Pharmacy in providing office supply.
Well, the 72-hour in the new regs has been removed, and so it's administration only. So you cannot send a patient home anymore with the 72-hour supply. We allow, if it's for a veterinary patient, you can send him 120 hours supply. 120 hours supply, but not in a human drug situation. I think that in the case of a pharmacy, you are between a couple of different regulators here, where one's got one set of standards, the other's got the other. You can comply with one, and you may be out of compliance with the other one, and then you run a risk that the other one may come in and attempt to correct you.
So it's in our best interest if we think we're likely to get inspected by the FDA to go ahead and follow their no office use policy.
You have to figure out what your business plan is and how you're going to do it, and if you're going to do it in compliance with California law, or you're going to do it in compliance with federal law.
Thank you. Item 2, facility I'm sorry. Do you want to come up? I apologize, I didn't see you.
My first question is, does the board intend to comment upon these draft guidelines?
I think we're going to take one of these at a time. They're separate guidances. So we have, I haven't heard a motion or comment yet from the board members on this one.
Okay. I would like to provide some information for you with regards to the 30-day limitation for your 503A pharmacies. That 30-day limitation is really very strictly written. And for instance, if a patient came in for a dye-free Allegra, we'll use that as an example, and they only need one a day for 30 days, I can no longer make a 90-day supply, which is a whole lot more economical for them. They may only want to purchase 30 days at a time from me, but I can't do that anticipatory. They're going to come back next month. They're going to get another 30-day supply because the way that this is written by the FDA is so limiting that we can't do that.
So this is for all compounding, not just sterile?
Yes, it is. 503A is for all compounding, all human
This
compounding.
requirement, the 30 days.
Non-sterile as well as sterile, yeah.
So for your compounders, we typically will make 100 capsules at a time, okay? And it's a whole lot easier economically for the patient as well as your pharmacies. It takes me 15 minutes approximately to make 100 capsules. Well, it'll take me about 12 minutes, maybe 13, to make 30 capsules. But then I have to do that every single month. You've got huge personnel issues coming up with that, as well as I'm much more likely to make a mistake if I have to do it 3 times than once for the same patient. Now, I'm not trying to get around the anticipatory or protecting the patients. We're dealing with one-off compounds. I make it for one patient who comes back 3 times. It's got a beyond use date that's very clearly 180 days. I'm not trying to violate any of those rules or regulations. However, it's in the best interest of the patient as well as your pharmacy to be able to make more than a 30-day supply in appropriate instances. This rules and guideline does not allow for the pharmacist to use their professional judgment in that case.
Thank you. Any comments by the board members? Nope. Okay, any more public comments? Otherwise, let's move on to 503B, which is item 2, facility definition. The guidance document was developed for entities registered or considering registering as outsourcing facility, and whether the one address means whether multiple suites for compounding constitute separate locations. According to the guidance, outsourcing facilities may or may not receive a prescription for a compounded drug product and are not subject to the interstate distribution restrictions that 503A facilities have. But they are required to compound all products under CGMP, label all products as compounded, and be subject to adverse event reporting. The FDA goes on to discuss that any product compounded in an outsourcing facility must be under CGMP and not those of a pharmacy. Conditions. Thus, the FDA concludes there can be no commingling of these products, those compounded under 503A and those compounded under 503B, in the same facility. All compounding in such facilities must be done under outsourcing facility requirements. So that kind of goes into what we've been talking about in terms of 503A and 503Bs being separately licensed and separate and apart and divided. If implemented, this policy would require California licensed compounding pharmacies that produce large quantities of non-patient specific compounded product to be regulated as outsourcers, not as pharmacies. As such, the guidance supports an enactment of the board's Senate Bill 1193 to permit separate regulation of outsourcers and pharmacies. The guidance goes on to state that approved drug products manufactured by a manufacturer would be easily differentiated from the outsourcing produced products due to the differing labeling requirements between outsourcing facility produced drugs and manufactured drugs. Any board comments? Jenny, you have anything on this one?
No, this one just seems pretty consistent with what we're doing, whereas the other one was a little different. We've got laws that seemingly are a little bit in conflict with it. I think this one is more of a harmonizing provision for where we're going once we have the outsourcing provisions in place.
Any public comments? Good afternoon.
Hi, I'm Robert Nickel, and we're putting together a 503B facility. And I know I've asked this question, but I'm just still concerned a little bit. I just want to be sure. We're currently licensing as a retail pharmacy, and then we're registering as a 503B. So when you come in and do the inspection, if your inspector comes in expecting to inspect a retail pharmacy and we say, no, we're a 503B, you're smiling, so just tell me what to do.
I can't tell you what to do. It's a problem we have until the Senate bills allow us to take a 503B as a 503B. We're aware of it, even when we do our out-of-state inspections. It's kind of a catch-22, so we'll get there.
But what do we look at? I think what you're asking is when we go into a 503B and and, that's a big and, they're compliant with the CGMPs, what do we look at?
Then you're going to be way above what our regulations
Thank
are
you.
requiring. I mean, our current regulations, 1735 and 51 are here, then there's 797 where we're going, and then there's CGMPs way up here.
Right,
So
I agree.
If you have that level of compliance, then shouldn't have too many problems unless, of course, like I talked about, those 15 violations we found in the 503Bs where you're not watching the little details, we can still catch you in that. But if you're compliant with them, you'll be fine with us.
Okay, so we go ahead and obtain a sterile compounding license?
Excuse me, I think we're cutting a little bit off topic. I think we're talking about this FDA guidance about 503As right now. So we kind of need to return to our agenda.
Our council we need to stay on agenda. 'Cause-
Okay, I thought we'd moved away from 503. I apologize.
Well, we need,
Well, there
yeah,
was
we just need to stay on the agenda items that are posted.
I think there was a comparison to 503A versus 503B, but my understanding is you're still on the 503A. Maybe I missed it.
No, we went to 503.
You did go to 503B. I missed
Yeah.
that. So sorry about that. My apologies then.
Okay, I think I'm clear anyway of how to proceed. Thank you.
Thank you. Any other public comment? Now move on to 3. Oh, I'm
There's
sorry.
one more.
Sarah Wallach again. I do understand the necessary harmonization between the federal and the state laws that's causing the separation, but unfortunately it does make a pharmacy choose between being a 503B and being a pharmacy that's providing usually patient-specific prescriptions for sterile, and it puts the patient in the position of getting a lower quality compound almost to a degree because the 503Bs are held to such a higher degree of compliance with CGMP, more environmental monitoring, personnel monitoring, that this does put the patients in a position of not benefiting from that higher standard of compliance.
Thank you. I think Jenny says we're pretty much consistent with it. We're just waiting for
We're
SB
consistent
1193.
with it. With respect to the comments, one of the concerns that we had is when we walk into a pharmacy, we know what the ratio is. We walk into an outsourcing facility, there's no staffing requirements at all, except that it's under the authority of a pharmacist. So there, you can't tell what kind of ratio. Consultation gets lost in an outsourcing facility. For us, the services provided by a pharmacy are important and they need to be individualized and locked in a pharmacy. An outsourcing facility which has CGMP requirements to fulfill, which are more manufacturing-like, where you don't have that interface with the patient, go ahead and do that if that's what you're, when the board decided to go with the outsourcing facility, this was kind of part of their deliberation, that we want pharmacies to continue to serve the patients, we want outsourcers to continue to focus on their manufacturing technique. That's why we don't allow it. We otherwise would walk in, and we have some experience in the past where the FDA used to allow pharmacies to also be licensed as manufacturers, and we would walk in and we wouldn't know what the heck we were looking at when we walked in.
Okay, going on to item 3, which is hospital and health system compounding under the Federal Food and Drug and Cosmetic Act. This guidance, the third document, states that outsourcing facilities are not required to be licensed as pharmacies. They may compound products in large quantities. They will be inspected by the FDA on a risk-based assessment, and they may compound with or without having a patient-specific prescriptions. The FDA notes that compounding in hospitals can occur under various forms. Some hospitals compound only products they need for its patients, while other hospitals compound for other facilities within their health system, such as clinics, infusion centers, and long-term care for administration or dispensing. According to this third guidance document, hospitals can compound pursuant to a patient-specific prescription, as well as perform anticipatory compounding for future use. Hospitals can also buy compounded products from outsourcers for use within their facilities. And some hospitals have also registered as outsourcing facilities themselves. The FDA goes on to repeat messages from the other 2 proposed guidance documents that it does not routinely regulate compounding by pharmacists or physicians, and thus is not aware of substandard compounding practices until an adverse event occurs. If compounding is done in an outsourcing facility, then the FDA has regulatory oversight, and the facility must adhere to CGMP. Higher production of compounded products can occur with longer beyond use dates without the risks inherent in compounding pharmacies. That's the assumption that the FDA has. They further state that compounded products should only be used when commercial products will not fit the medical needs of a patient. The guidance states that in hospital pharmacies, compounding must be done in accordance with all provisions of regulations governing 503A pharmacies, and such pharmacies may be subject to regulatory action for violation of new drug approval, adequate directions for use, and CGMP requirements. The guidance goes on to state that in a hospital or health system, compounding may occur after the receipt of a valid order for an identified individual patient, or be done in limited quantities in advance of receipt of an identified individual patient. They also indicate that it does not intend to take action when a hospital pharmacy distributes compounded drug products without first receiving a patient's specified drug order if 1, the drug products are distributed only to healthcare facilities that are under common ownership of the hospital pharmacy and that are located within a 1-mile radius. So this is probably the biggest change, I think, in these regs is this guidance, because we do have a centralized hospital repackaging license in California that allows 75 miles, not 1 mile. 2, the drug products are only administered within healthcare facilities to patients within these facilities pursuant to a patient-specific prescription or order. And 3, the drug products are compounded in accordance with all other provisions of Section 503A and other applicable requirements. The FDA states that the 1-mile radius is necessary because a health system pharmacy that compounds drug products without patient-specific prescriptions within its healthcare system across a broader geographic area could function as a large manufacturing operation, but without the necessary standards that are inherent in 503Bs and CGMPs to assure drug quality. If such a pharmacy contaminates or otherwise adulterates or misbrands a compounded drug, there's a potential to harm many patients. The FDA offers that outsourcing facilities which are subject to CGMP and other conditions can compound and distribute drug products to healthcare facilities nationwide without first receiving prescriptions for identified individual patients. They state that a hospital compounding pharmacy can register as a 503B if it intends to provide compounded drugs to facilities such as hospitals or other clinics outside the 1-mile radius of the pharmacy in which the compounded drug, where the drug is compounded, without first obtaining a prescription for an identified individual patient. This guidance conflicts with the regulatory provisions that the Board of Pharmacy enacted under Business and Professions Code 4128. Centralized packaging pharmacies currently our hospitals are allowed under common ownership to secure unit dose packaged medications from a centralized pharmacy within the 75-mile radius. So this also affects not only sterile, but all packaging?
The repackaging that we allowed centralized packaging pharmacies to do, which can be which can be pill form or capsule form.
But the FDA requirement for the 1 mile, is that for everything or just?
Well, if you won't be able to do the compounding part, it's silent on the repackaging part, because what they're really looking at here is the compounding side, which was half of what the centralized packaging pharmacies could do. But their solution to that is if you want farther than 1 mile, you could become an outsourcer.
That means all our centralized hospital repackaging pharmacies that exceed that 1 mile radius will have to apply for 503B.
And they'll also have to apply for a manufacturer license so that they can repackage the drugs, the solid dosage form drugs, for example, into unit dose packages as well.
Board comments? Public comment? How's it impact those hospitals out there? I don't see anyone, does anyone in here have a centralized hospital repackaging? I don't see anyone here.
Not anymore, there were.
You do? How's this going to, you want to come up and let us, how's this going to impact you?
Well, while he comes up, if I can just, my biggest concern is how we're going to license the outsourcing facilities in this state. I think the central hospital pharmacies need to be aware that not only you're going to have to be a 503B registered under CGMP, the bill that's out actually forbids you from doing patient-specific compounding, so you will not be able to do TPNs. I know a lot of the central pharmacies are doing TPNs, and that will be eliminated as the process goes forward, and that I think is extremely significant in my mind. So it's just, this is a moving part, but I want to make that clear.
Robert Easton, Scripps Health, and we do have a centralized. And so we aren't doing TPNs, but when this dropped on April 15th, we had about 2 weeks of denial, and then and they said, well, let's see what does it take to be a 503B. And really what we're doing is we're doing the compounding, we're doing the unit dose repackaging of oral tablets, so the patient-specific isn't, but if we want to continue, then yes, that's how we're viewing it right now.
Do you think you're going to be equipped to manage all the CGMP requirements?
So I think from a facility standpoint, I think we're actually in pretty good. There's a lot of forethought that went into the facility design. I think a lot of the quality assurance, the testing, environmental sampling, we are much further along than a hospital pharmacy, I think, in a lot of ways because of the way it was built from the ground up. But there's still a good distance to travel, I would say.
Well, you are the reason we even have this license form as a centralized packaging pharmacy, so it was a short-lived program.
Do we have any idea when these FDA guidance documents will be final?
Well, their comments are due in mid-July. They'll leave them out there for a while, but no, we're still waiting for them to finish some of the documents they needed to produce in 2015, and those are still undergoing review internally. On the compounding side, they're a little more prolific than they are on the track and trace side, but who knows? It's the FDA.
It's kind of like our sterile compounding regs. They have enough.
Well said. I just didn't realize what we were dealing with on the sterile compounding regs.
There's some ramp-up time that facilities will have that have a centralized hospital repackaging license.
There you go.
Any other public comment? Lynn?
Very good, Amy.
So on some level, this seems like there's a little East Coast, West Coast discordance because there are hospitals in the East Coast that have 1,000 beds, and 3 blocks away they have another, hospital in their system with 600 beds and what have you. So it seems like if the FDA was really going to do this right, they'd have a limit on how much you could do rather than a 1 mile radius. So the things that concern me are that there's just, we've set up hospitals so nobody has any delayed gratification, right? They can't wait for something to be made. It has to be ready for them. And you can't have extended dating or even reasonable, you can't do sterility testing and what have you if you're doing them one by one, right? So if you're going to put it in a Pyxis machine or do any of those kinds of things that allow for immediate access, then you've got to batch them somehow or get them from an outsourcing group. So I think the concern is when you have a couple of hospitals and we're all running on pretty narrow margins and they're not very far away from one another, that they would make all of the product at one facility and share it with the others. This will affect our hospitals that are on common licenses. So in our system, we have, I think, 3 facilities that have at least 2 hospitals on the same license, and they can't do anything centrally because they're more than a mile apart. So that seems a little arbitrary, and it would be a better way to look at it is by volume. So if their concern is that we're going to kill too many people all at one time, then they should limit how many people that is, I guess. But you know what I mean? Well, I mean, there's nothing about a mile that makes it, and I think that's a difference between having space and what have you, but there's nothing about putting that bag in a delivery van and moving it 5 miles that makes it less safe. I mean, that piece is not the risk factor. So it just doesn't, it seems more like people in Rockville, Maryland going, oh, I think we'll do, how far do you think we should go? Oh, a mile. That'll keep the people in Boston and New York off our backs, and the rest of the people don't matter, I think, is sort of how that goes.
Any input from CSHP? Didn't they sponsor that original bill?
No, we were the sponsor. It was our bill.
Centralized
Yeah,
hospital?
we saw the value in a consolidated repackaging location that could be separated, where they can, one, get the quality of the equipment that they need in order to make it efficient for a hospital.
I mean, I would agree that we're going in the direction of CGMP, but maybe the rate is a little quick for some organizations.
Well, I will tell you that the woman whose name at least is on this, I met a couple weeks ago, and I specifically brought up the fact that that in California, our consolidated hospital licenses may run 30 miles, which puts the whole hospital on a consolidated license, compounding product that it's shipping. Now, that hospital pharmacy better get renamed or become relicensed as an outsourcing facility, which is going to cause a problem for them because they can't do patient-specific.
It's got to move.
Well, but
Right.
that's part of the problem. That's exactly part of the problem. You can't serve even the consolidated hospital license in
Exactly.
California with this particular construct, which
Right.
I think should trigger the hospitals, at the very least in this state, to be pushing back pretty strongly on the FDA, regardless of what the board does. There is certainly an issue for the hospitals.
Yeah, no, I'd agree with you on that. And I think that that's just, it's sort of just a different practice here and the consolidated licenses that I know that are your favorite. But you're getting
We have
used
lots
to
of favorites.
Thank you, Lynn. Any other public comments? Any actions from the board members? Nope. Okay, that's it for the speeding meeting dates for 2016. The Enforcement Committee will meet on August 31st, and a date in December that will be finalized and posted on the board's website. Thank you, everyone. Meeting adjourned.
Wow. And 45 minutes early.